Today I'm going to be talking about artificial lighting and fertility in the mare. And so I titled my talk, That's Not a Light, This is a Light. I realize that's probably dating me a bit. I don't know how many people in here actually remember the Bud Light slogan that they use for like Super Bowl commercials. But anyway, I feel like this is applicable because not all lights are created equally. And when somebody tells me that their mare has been under lights, I'm like, was it really under lights? Or, that's not a light, this is a light. So anyway, we're going to be talking about artificial lighting and fertility in the mare. And my hope for you by the end of this talk is that you will not only be an expert on colostrum banking, since we covered that in the welcome, but you'll also be an expert on artificial lighting. So how do you become an expert on any topic, right? It's where you can walk away and be able to understand the five W's of any situation. So for the purposes of this talk, where the 5 W's are the who, what, when, where, and why. And so ultimately, if you understand the who, what, when, where, and why, you're going to understand the how, right? So who are we talking about artificial lighting with? Who, and what are we doing? And when does it occur? And where is it occurring? And then why, right? So obviously the who's pretty easy because I have a captive audience here, but the who is you guys. The who is horse breeders. And I would actually say to you that everybody here in this room should understand or have a basic understanding of what artificial lighting is and how it pertains to fertility in the mare. And so if you are interested in breeding a barren mare or a maiden mare, or you have an early foaling mare, then I would say you should understand the physiology and the importance of artificial lighting. So if we're going to be an expert, we have to really understand the what and like the how it works. So in order to do that, we have to understand the physiology that takes place with the mare. And we have to go back to understanding that mares are long day breeders. So in order for this physiologic process to take place, light comes in and is gathered by the retina in the eye. And when there is less light, the pineal gland in the brain responds by producing more melatonin, okay? And then the melatonin causes a decreased reaction or decreases the production of GnRH from the hypothalamus, which then ultimately decreases the production of LH and FSH or in the mare. So basically, if we're going to change the physiologic response, we're going to cause the mare to reduce less melatonin. We're going to do that by tricking her into thinking that the days are getting longer. So the idea is that the mare is going to think, oh, the winter was really short. The days are now getting longer. I'm going to ultimately produce less melatonin, which is going to increase my GnRH. It's going to increase my LH and FSH. And so I'm going to start cycling. So that's the idea. There are 2 methods of manipulation for this pathway. There's the traditional method, which involves the 10-foot candles and at least a 200-watt bulb, depending on the height of the ceiling of the barn, and 16 continuous hours of light. This is where, I don't know if anybody's done this, but you take the newspaper and you walk around in the different corners of the area where the mare under lights is. And hopefully you don't need reading glasses, but you should be able to see in every aspect of that space, be able to read your typical newspaper print. And if it's not bright enough, then you won't be able to read it. So this is a really important consideration when you're looking at your barn structure. It's important to look at, all right, do I have windows that the mare can put her head out the window? Is there an issue with the ceiling height? Do I have a mare that's in a shed where I can't keep her in a defined space? So those are all challenges that come with traditional lighting. The newest player in the field is the light mask. And so the light mask, each individual mare gets a light mask, and it's a single eye cup where there's a blue light emitted from the single eye cup. And these light masks are really handy because they have replaceable components and there are rechargeable options. And the blue light mask or the light mask is a great option because it complements many management styles. So you don't have to have a setup where every mare gets her own stall. You can choose to keep mares turned out more. If you're shipping a mare across the country for breeding purposes, she can travel in that light mask and you're not going to like decrease or upset your lighting system. So those are the methods of manipulation. So when would we start this process? So if we're thinking about the purpose of doing it, we're doing it because we're trying to convince the mare that winter has gotten shorter and that she should now start cycling because spring is coming. So the idea is that we would start this instead of skipping winter altogether, which especially on a day-to-day sounds really nice. Instead of skipping winter altogether, we're going to make winter shorter and we're going to start spring earlier. So we do that by putting mares under lights 70 days prior to the desired date of breeding. So I want to make sure everybody understands it's not the desired date of the mare being checked in foal. It's the desired date of breeding. Because can any of us really predict when the mare is going to be checked in foal? I'd like to believe that I could predict that every mare will be checked in foal like right after 14 days after I have bred them. But the truth is that we want to aim for the desired date of breeding so that if there's any kind of diagnostics that need to be done or things aren't going as planned, she's cycling, she's ready to go, and we can start doing those things. So 70 days prior to the start of breeding for most places is December 1st in the Northern Hemisphere or July 1st in the Southern Hemisphere. And I kind of like to use Thanksgiving as my cutoff because if I think about it at Thanksgiving, then I'm getting out my masks or I'm checking my timers or I'm checking my light bulbs. I know that everything's ready to go for December 1. So Thanksgiving is a great, okay, eat your turkey, recover from your turkey coma, go check on your lighting system. If we're talking about early foaling mares, that's a little bit of a different situation because every veterinarian has a different definition of when an early foaling mare is. For me, I consider March 1 or before to be an early foaling mare. So if she's an early foaling mare, I like to put those mares under lights for the last 100 days. And that roughly correlates to, it's the same period. It's like, think about it on Thanksgiving Day, make sure everybody's under lights on December 1. So again, I want to reiterate, remember that mares have to have at least some short period of a short day length in order to respond appropriately. So here are some examples of lighting systems, depending on your setup. See if this one is going to work. So this one up here in the upper left, I could use my mouse too, that's probably in like Texas or someplace like that where they have stadium lighting around a dry lot. And so they can house all their mares that are under lights in one pen. I don't know what they pay for that kind of lighting, but you could walk around in that field with a newspaper and be like, yeah, I can read a newspaper. So that's one option. That's not a very common option in the Northeast, but it does exist. And then you can see here in the middle, these are mares grouped together, probably in an indoor arena or in a barn. They seem to have plenty of light, but you can look back here in these corners and it's a little bit like, this one back here, is that mare getting enough light? Maybe not. But I mean, for the most part, that space seems to work pretty well. And then you have the traditional like pens or stalls where each mare has their own individual light. I put this picture in there because I wanted to draw attention to the fact that you can have an appropriate amount of light in the stall itself, but if a mare can put her head into the shed row or into an aisleway and there's not lighting in that space, then potentially it's not an effective lighting system. So, and then here's your traditional light mask over here produced by Equine with a mare that's happy outside in a pasture with her mask on. And then interestingly enough, Equine is now producing a traditional lighting option. I don't know the details on this particular light, but the idea is that it's the same concept, traditional lighting, you hang it above the stall. But if you're looking for more information about that, we can put you in contact. So that's the whole where. And then we talked about this a little bit before. This is the why. But a lot of times people will say to me, like, I don't have a thoroughbred mare, or I want to wait until May. Or I think like all of the veterinarians in this room have heard the, I don't want to have a foal in like before April, you know? So then everybody decides in May 1 that they want to now start trying to breed their mare. And what I would say to you is there have been so many times for me where either people change their mind and then they decide they want to start earlier, or when we start to look at the mare in March, we end up using the entire month of March to watch that mare as she goes through a transitional period. And so my personal opinion is that if you can get the mare to go through that transitional period earlier, then you're not going to pay for me to come out and check the mare and go, yep, she's still transitional. Yep, she's still transitional. There are drugs that we can give them, but it's just cheaper and easier if you get the mare going earlier so that nobody's waiting on the mare when we decide to go. There are obviously breed-specific advantages in your non-pregnant mare for starting early, like in the thoroughbred and in quarter horses or any horse breeds where they have a like a futurity type system. Older mares, any mares with known fertility problems, I feel like those mares should be under lights, because you never know when the first time you look at that mare, like what are the diagnostics that you're going to need to do? And you could have put her away at the end of the year and done all the things. And then when you start again in the next year, you could have something totally different. And if you can get started on those things and knock out the diagnostics earlier in the season, it works out better for everybody. Availability of the stallion. Sometimes the stallion's not, he's like competing, or the stallion's not local, or you have to use frozen, or there's just so many variables there. So if you're waiting on the mare and you have to wait on the stallion, it's just a lot of variables you can't control. Availability of the vet. I mean, I'm going to say this right now is we have a lot of veterinarians that go through maternity leaves. And sometimes if you're maybe not right at Millbrook Equine, I want to point that out. But if you have a veterinarian who does your breeding work and she's due to foal in like May, maybe you should like think about if you want to have any mares pregnant that year, aim earlier in the season. And then obviously there's the performance schedule for the mare. So if the mare is under lights, then that's one less thing you have to worry about. So I consider lighting to be just another tool in your toolbox. And if you have a barren mare or a maiden mare, you just do it because it simplifies a lot of things. You don't have to breed them in February, on February 1st or February 15th. You don't have to. But if she's cycling and you've done the diagnostics that you need to do, life's a lot easier. And then for the pregnant mare, there's been research to show that it shortens gestational length on mares that tend to go long, and that it definitely improves post-foaling fertility. I've had a number of mares that will foal early January, February, and then they just stop cycling. And then you're at it for 60 days trying to get the mare to start cycling. So that's a method that you can utilize to potentially prevent that from happening. So in summary, everyone should consider lighting non-pregnant mares and early foaling mares starting December 1. Artificial lighting advances cyclicity in empty mares and optimizes fertility in early foaling mares. You should evaluate your lighting system because remember, just because you have a lighting system doesn't mean that it's appropriate. And consider a light mask if your structures or your management style isn't conducive to the traditional techniques. And don't forget that they do need exposure to a short day period. So they can't skip winter altogether, and you can't leave the lights on indefinitely. 16 hours, and there needs to be at least a couple of months of true winter for them. So again, thank you to our sponsors, Doc Lanes, Minitube, VMRD, Merck Animal Health, Platinum Performance, and Equiloom. And I forgot.
I am Dr. Alana King, and I'm the repro specialist at Millbrook Equine. And I'm excited to talk to you guys today about collecting and processing semen for cooled transport, because there's actually been a lot of new developments in the field in the past couple of years. So for those of you who have stallions and you've been doing this for a while, or maybe those of you who are new and have, they're hoping to do this soon, there's going to be a lot of interesting stuff we're going to talk about today. If you're a mare owner and you have no interest in ever having a stallion, it's still going to be useful to you because it's important for you to understand the parameters of what makes a quality semen sample and be able to look at that semen and know that you're getting a fertile product. So we'll start at the beginning, the semen collection. If anyone's not familiar with this process, basically the stallion comes into the breeding shed. They mount a phantom or a dummy mare. The penis is diverted to the side and put inside of an artificial vagina, which is usually a latex bladder that's filled with water and connected to a collection bottle. And so the stallion ejaculates into the AV. We're able to recover that semen and then take it to the lab for analyzing and processing. So the tease mare is going to be one of the most important members of the team in this whole process. That's Tequila down on the right there. She is our official Millbrook Equine mascot, and she's also our tease/jump mare. She is actually an ovariectomized mare. Obviously, if you're doing this at home and you have mares that are in heat, it works out very well that you can use them as jump mares or tease mares because they come into heat when you need them, and then you can use them to stimulate the stallion when you need them. But for a busy collection center like ours, where we do maybe like 7 collections in a week or more, we just can't maintain enough mares to always have one that's in heat. So what we do instead is we ovariectomize the mare. In the mare, the behavioral estrus is related to estrogen, but it's even more related to progesterone. So progesterone provides a negative behavioral response in the mare and keeps her out of heat, which is why we can give show mares Regimate and it keeps them out of heat. And so if we remove that source of progesterone by removing the ovaries, then a certain percentage of mares are always going to have behavioral estrus signs when they're in the presence of a stallion. It's never going to be as good as a natural heat, but it can work quite well, and it works very well for us. If you don't have access to any mares, you can use estrus urine collected from a mare in heat, and you just put that on a rag or a cloth and rub it on the stallion's nose, on the breeding mount, and in some cases that will be sufficient to stimulate the stallion. But a mare is going to be obviously the best option. And then so we place her here. Usually with the novices, we place them right here next to the mount. And then we redirect the stallion to, when he tries to jump on the mare, to jump on the mount instead. And it usually only takes 1 or 2 attempts at doing that. Once the stallion figures it out, we usually can move the mare to a safer location, usually like outside of the fence here. And then in some cases, we can remove the mare entirely and they don't need the mare at all. Once they arrive in the breeding shed, they know what they're doing. So after the stallion is exposed to the tease mare, but before we allow them to mount, the next most important thing to do is the washing step. And every stallion that gets collected has to be washed every single time they come into the shed. So this is where obtaining a good sample, a good quality product that you're shipping out starts. Because if you have a lot of dirt and debris in your sample, that's going to introduce bacteria in the sample, which is going to negatively affect the quality of the semen. So we wash them at the beginning. If they, if they're not getting the job done, they've mounted a bunch of times, they've kicked up a bunch of dirt, we wash them again. So it's really important to start with a good sample, because once that dirt gets in there, the finer particles can't be removed with a filter. And so we need to make sure that it's clean from the beginning. The other reason that we do this is for training purposes. So it doesn't matter if you collected that stallion yesterday or this morning and he's already clean, you wash him again, because most stallions aren't really particularly fond of this procedure. They want to get to business. And so for behavioral reasons, we make sure that they know that they don't get what they want until they get washed. And that's where Lee comes in. This is Lee over here. She's our stallion handler. And it's important, if you're going to be doing this, to have a really, really experienced handler, because things can get very dangerous in the shed very quickly. So Lee doesn't put up with anything. Once you get bad habits in the shed, they can be extremely hard to break. So you want to make sure that you do this right from the beginning. A lot of people are worried when they bring their stallions to us that they're show stallions. You know, they're going to be going to shows and being exposed to mares there. They're going to learn bad behaviors or learn breeding behaviors in the shed, and then they're going to do those behaviors when they go out to a show. But it turns out stallions are pretty smart, and they usually understand the difference. And so we try and give them cues so that they know right now it's okay to be a breeding stallion, and right now it's not okay to be a breeding stallion. So you can see here that Lee has the chain through the stallion's mouth instead of over his nose. And that's our cue in our shed that that stallion can be a breeding stallion at that time. And then, excuse me, when Lee turns the stallion out, she'll put it over his nose so that he knows no nonsense when that setup is in place. So the artificial vagina is going to be probably the most important part of this whole thing. So this setup is really going to affect how successful you are and how quickly you can be successful. If you have a bad setup for your AV, you're just not going to be able to get the stallion collected. So I have here some pictures of some of the more common AVs that we use in this country. There are others, but for most stallions, one or the other of these is going to be workable. So this is the Colorado AV. It's basically a hard plastic shell with a latex liner that's elastic to it. And then the water goes into that chamber. And then there's another latex liner that goes on the outside that has the connection to the collection bottle. It holds a lot of water, which is an advantage in terms of the fact that it will not cool down very quickly. So if it's taking a long time to get the job done, you don't have to reset the AV. But the disadvantage is also that it holds a lot of water and it's extremely heavy. So my preference is always to use the Missouri AV, which is the one shown here. It's basically just a latex bladder with a leather case on it. And so it's really lightweight. It can be adjusted easily. They come in different sizes, which is really important also because you need to have the right size AV. The stallion needs to be able to go all the way through the AV and ejaculate outside of it. So if you look at this picture of the Missouri, you want the end of the penis to be actually on the outside part where the bladder ends. This is an image of an open-ended AV, so you can kind of see what I'm talking about. You see that the end of the penis is all the way through. And that's for two reasons. One is that if the stallion ejaculates inside of the AV, the end of the penis flares at the very end. And if it's inside of the AV when that happens, it gets very uncomfortable and they'll tend to back right out when that happens. And the other reason is if they do ejaculate in there, then the semen flows through the very hot part of the AV and it can damage the sperm. So you want to make sure that you have the right size. All right, so getting it just right. The two things that the stallion responds to in terms of AV preparation, which are temperature and pressure. The temperature you want to be around between 42 and 50 degrees, so it's quite hot. I should say Celsius. And most stallions like it on the hotter end. So you can use cooler, but in most cases, hotter is better. I've never had a stallion who disliked it being hotter. So I tend to aim for like 47 degrees. For pressure, that's much more highly variable by the stallion. And so we have stallions that like it quite tight, and then other ones who want almost no pressure at all. We have one stallion that just wants a little sprinkle of water in there just to make it hot and no extra pressure at all. So you have to kind of play with it a little, see what the stallion likes. And then once we find out what they like, we weigh it. So in this image, you can see that I'm just using like a luggage carrier scale. And we just get like an idea of how heavy it is, which tells you how much water it's filled with so that we can prepare it exactly the same way the next time. So we have very detailed records of the stallion's likes and dislikes. Novice stallions will usually accept almost anything, but as they get more experienced, they get a lot more particular. And usually if it's not just perfect for them, then they won't do it. And then finally, the lube. So you want to use a non-spermicidal lube, and you don't want to use too much because it heats up inside of the AV and it will drip into the sample and damage your sample. So you want to be careful not to use too much of that. All right. So once you have the sample in the bottle, you want to quickly go to the lab. Semen doesn't like to sit in its own fluids for very long. So the first thing that you want to do is make some quick evaluations and then put it in extender as quickly as you can. The first thing that you want to do is look at the volume. Okay, so you can see in this sample, I just measure it right in the falcon tube. If you want to get fancy and get a very accurate measurement, you can use a graduated cylinder. So we have about, 37.5 mils in there. Usually you're going to get between 40 and 120 mils of semen from the average ejaculate. Then the concentration is the next thing that you want to determine. You can get a rough idea of what the concentration is just by looking at it. So you can see in this image, this one on the left is much more transparent than the one on the right. And so the sample on the right is, just by looking, I can tell that that's going to be a much more concentrated sample than the one on the left. And then you can run it through a machine in order to determine what the actual number of sperm per milliliter is. These are the most common machines, and they actually do a more sophisticated version of what your eye is doing. So they're actually just, you're diluting the sample in a see-through cuvette, you put it into the machine, and it measures how much light passes through. And that's how it determines an estimate of what the concentration is. So you can see that it would be inaccurate if you have a very dirty sample. It's going to give you a higher concentration because the optical density will be greater. So in our lab, we like to use the nucleo counter, which is the gold standard for counting sperm. It's very expensive. So if you're setting up a home lab, then you probably aren't going to be able to start with one of these. But it basically, well, you take the sample, you add some reagents, and it stains the nucleus of each individual cell, and then it counts them. So it's not going to count dirt or anything else. It's just counting sperm cells. And then once you have those two numbers, the next thing that I do is I add extender to the semen, because it doesn't like to sit there without anything in it. And we're going to talk a lot about extenders in a few minutes. But basically, I extend it 1-to-1 immediately so that it's not sitting raw on the counter. And then you're going to do a little bit of math, which I know is everybody's favorite thing. So the first thing you want to know is what the total sperm is. Just concentration times volume. And that gives you the total sperm in the sample. For most stallions, they're going to be on average about 8 to 10 billion, but we see anywhere from 4 to 20 billion. And since some of our really big stallions, we can even get like 25 or 28 billion. More math. I've just given you a few examples of calculating the total sperm. I get a lot of clients who are very hung up on either the volume being too low or the concentration being too low, and they get worried about that. But as you can see from these examples, the first stallion has a very large volume, 80 mils. very low concentration, 100 million per mil. And the second stallion has a low volume and a high concentration, and they both have the same total number of sperm in the ejaculate. Okay, so really it's, in terms of the amount of sperm you're getting, it's the same. And that's because the volume and concentration are dependent on how much fluid is added to the ejaculate at the time of ejaculation. So this is a diagram showing you the accessory sex glands of the stallion. They have a bulbourethral gland, a prostate gland, and a vesicular gland, and also the ampulla adds fluid as the ejaculation is occurring. And so if it adds a greater amount of fluid, you're going to get a greater volume and a lower concentration. And if it adds less fluid, you're going to get the opposite. And that really is dependent on how long the stallion has teased. So if you have a stallion that lives in a barn with mares and he teases mares all day, or maybe it took you a really long time to get him collected, you're going to have a higher volume and a lower concentration, and that's okay. The actual total number of sperm, which is our calculated number, is really dependent on the size of the testicle and the health of the testicle. Okay, so you can see here, this is a diagram of like the tubules inside of the testis. So it's just packed with these little tubules that are making sperm all day long. So a gram of testicle can produce 18 to 20 million sperm every day. That's all it's doing. And so if you have a larger testicle, you have more sperm production. And you can see here on this picture, these are two cut testicles on two stallions that we castrated on the same day. The one on the left was very healthy. You can see that it's large. It was producing a normal amount of sperm. And the one on the right was an aged stallion who had degeneration of his testicle. You can see that it's very small and it's dark because it's not producing any sperm cells. So once you've done that, the next thing to evaluate is motility. It's nice to evaluate a little bit of the raw sample if you want to before you add the extender, but really the extended sample is going to be usually easier to look at because it's going to be less concentrated, and it's also going to usually pick up a bit with the things that are in the extender that are going to help it out. So you're going to usually report your measurement of what the motility is based on your extended sample. So this is a picture of a stallion that had, oh, hold on. Good motility on the left. If you're evaluating it with your eyes, you kind of decide, okay, is it greater than 50%? First thing you want to do, actually, I should back up, is get total motility. So how many of those sperm are moving at all? And then you want to determine how many of those sperm that are moving progressively forward in a straight line. It doesn't have to be a perfect straight line, but basically they have to be making a motion to go forwards in order to be counted as progressive motility. And that progressive motility is the number that we usually focus on in terms of the fertility of that sample. So this one is, it's going to let me play it again. I don't know. Sorry. That one is who I would consider pretty good. There are some that are circling, so those wouldn't be counted in the progressive category. And then this one, you can see there's a lot of dead sperm there. And they're also moving a lot more slowly. So the velocity of the sperm is also important. Using your eye, so notoriously evaluating semen with your eyeballs is usually going to be less accurate and usually falsely increased over the actual number compared to if a machine measures it. So in our lab, we like to use this machine. It's called the androscope. It's new in the last couple of years, I believe. It's like a portable machine. And you just fill up a little chamber and then stick it under the little microscope that's in there. It connects to your laptop, and it will give you a readout of the parameters of the sperm. So this is, I apologize, it's not the greatest picture, but this is sort of an example of the readout that it will give you. And you could see that it's tracked the motility of each individual sperm on the screen. You can see the red dots are dead ones. The green ones are moving really nicely, progressively forwards and pretty fast too. And then the yellow ones are going in circles. So they would not be considered part of your total motility. And then it gives you the number breakdown here on the side. So for this sample, the total motility was 90% and the progressive motility was 70%. And then you're going to measure several fields to make sure you're not getting a biased field. There are other machines as well. There's the iSperm, which is pretty decent, but has kind of a learning curve to it. It's sort of hard to get used to. And then there's also the big Hamilton Thorne machines that are like a big, huge machine. They're the gold standard, but they're also very expensive. All right, so just the same kind of math with motility that we were talking about with the total sperm. If you take your total sperm and you multiply it by your progressive motility, that gives you the total progressive motility in your sample. And you can see, again, people get very hung up on the motility. Was it good? Was it over 60? That would be great. Ideally, it is over 60. It should be at least 30% in order to have a quality sample. But ultimately, when you're shipping out the semen, you have to ensure that there's a minimum number of progressively motile sperm. And it doesn't, if you have 30% motility and you ship more semen, you can still achieve that number. So it's not the end of the world if your stallion doesn't have 90% motility. It just means that your shipment will have to contain more total sperm in order to get the minimum number of progressively motile sperm that you need. All right. So we're going to talk a little bit about the extender. The next step in processing is to extend it appropriately. So we've already extended it 1-to-1 while it's sitting there and we're doing our math. But now we need to figure out the ideal extender ratio. So extenders do a lot of different things. The most important thing that they do is they stabilize the membranes of the sperm. So the sperm membranes are very susceptible to breaking down over time. And so we need something to kind of bind to them and keep them stabilized in storage. The other thing they do is they provide sugars. So the mid piece, which provides all the motion to the tail, it is packed with mitochondria. If you remember from grade 11 biology, the mitochondria are the powerhouses. They do cellular respiration. Everybody remembers that, right? And they produce energy, tons of energy, and also free radicals. So they rely on sugar. So the extender has to have sugar to keep those sperm happy and motile. And it also has to have antioxidants to deal with all the free radicals that are being produced by all that mitochondria. It also contains antibiotics. Breeding is not a sterile event. Bacteria is going to get in our sample no matter what. Semen is a great medium for bacteria to grow, and this is going to be stored over several days. So we want to make sure that there are antibiotics in there. And then finally, buffers. So all those metabolic products change the pH. So we have buffers in there to keep the pH stable. We divide all the extenders into types. And because the membrane stabilizer is the most important, we kind of base the types off of the kind of membrane stabilizer that it contains. The first extenders were actually made out of half and half cream. It turns out that there's products inside of the milk, mostly the casein, that are very stabilizing for the membranes. And but unfortunately, milk also contains things that the sperm don't like. And then it was discovered that if the milk is heated, they can get rid of a lot of those products. So most of the extenders on the market now are based on skim milk powder. And then we have our next class, which a lot of you maybe remember who do stallion work when it came out, INRA 96, which is based on caseinate. So they've isolated the casein and changed it a little bit so that it's more chemically defined, is what they call it. And that's why INRA 96 had performed so much better in some stallions than the older extenders. Now, in the last couple of years, we have something even better, which is caseinate plus cholesterol. And so that it's discovered that the cholesterol further helps to stabilize that membrane. And so now we have even more options that work even better than the INRA 96. And then finally, in the last 2 years, a synthetic one came out where it's proprietary, so I can't tell you what's in it, but it's entirely synthetic. It's not based on milk or anything else, and it can support the sperm for a very long period of time. The other component that sperm cells tend to be sensitive to is the antibiotics. So there's lots of different variable antibiotics that we can add to these extenders to try and see which one the sperm cells tolerate the best. So usually when we have a stallion come in for the first time, we're going to try them out in a bunch of different extenders. And I try and choose one from each different class, some that have different antibiotics, some that have different membrane stabilizers, and try not to overlap too much so I can tell what it is about that extender that stallion likes. And then we're going to check the semen at 24 hours, 48 hours, 72 hours, and beyond if it's still surviving after that, but it usually isn't by that point. So here is an example of like an extender trial that I might do. I have Botu semen, which is skim milk powder based. It contains penicillin and gentamicin. Then maybe I choose an Equa Plus, which is also skim milk powder based, but it contains a different antibiotic. Or you can also get some with no antibiotic and you can add your own. So if you have a stallion that's just not agreeing with any antibiotics, there are formulas for how to add those different antibiotics in there. I would try INRA 96, which is a caseinate based and then contains some similar antibiotics as our first one. And then this Botu Semen Gold is the one I was talking about that has the cholesterol. And we've seen some really great results with this in our lab, where stallions that are not shippable in any other extender, they respond really well to this one with cholesterol. So a lot of labs are using this more and more now as a default extender. The other extender, which is the synthetic-based one, is called Beyond. It's a really neat product because it's been designed to hold semen motility and viability for much longer. So usually we ship semen overnight, and when we inseminate the mare, ideally it's not older than 48 hours. But this Beyond has been shown in their studies to hold semen and maintain fertility up to 14 days. And so in my lab, I would say that's maybe generous. I find that in the stallions that we've tested it on, they usually maintain decent motility up till day 7 to 9. And you can see in these graphs on the left here, this is stored at 5 degrees Celsius, so shipped the standard way in an equitainer. And you can see at day 7, it still has 40% progressive motility, which is pretty decent for a week out. And it still has somewhere around 30% at 2 weeks out. So it can be really beneficial in some situations. And the other thing that it can do is it can store semen at closer to room temperature. So we've had some stallions that really don't. Some stallions, their fertility looks excellent. And as soon as it goes through the cooling process, it gets damaged and it really doesn't like that. And those stallions were previously unshippable. But with the Beyond, we can actually ship those in an equitainer or a box that has no ice pack in it. It basically just stays at room temperature. It can't survive as long as 14 days, but it can survive at least long enough to get the semen where it needs to go. So those are really the two main uses for Beyond. I think there's a tendency when there's a new cool product like that to be like, well, we should just use it for everything because it's better. They've actually shown that INRA at 2 days out is better than the Beyond. And so it's not going to replace what we're already doing. But if we're having things like, you know, if you're shipping semen on a Friday for a mare that wants to ovulate on a Monday or Tuesday, it can be really great because then the semen will still be good on Monday. Whereas previously, you would have to just hope for the best that she was gonna, you know, you could push her to ovulate or that the semen would still be good on Monday. So, and then obviously our stallions who don't ship well is the other great use for this. All right, so these are the processing parameters. I don't want to spend too much time because I know people don't like numbers that much. But if you're going to be processing your own semen, it's an unfortunately unavoidable fact that you're going to have to know numbers and do math. All right, so the minimum breeding dose is going to be 500 million progressively motile sperm. Does that mean that we can't get a pregnancy with 200 million progressively motile sperm? No. It just means that 500 million is where you achieve your maximum pregnancy rates. If you go beyond 500 million, you're not helping anymore. So adding 1 billion progressively motile sperm isn't going to get you better pregnancy rates. So that's usually the number that we aim for when the mare is being bred. Because that's the number we want when the mare is bred, it means we want to ship more because we know some of them aren't going to make it through the cooling process. So we ship 1 billion, usually, as a minimum. Sometimes I'll even ship 2 billion if I have it. The final concentration is going to be 25 to 50 million sperm per mil. It's going to be greater if you're using Beyond. It's going to be double that if you're using Beyond. And then the final volume, we try and keep between 40 and 60 because that's the size of the syringe for insemination. And people get cranky if you ship them 80 mils because then they have to use 2 syringes. They also get cranky if you ship 20 mils because they feel like they're not getting a proper dose. And then the final ratio should be 1 to 3. So we shouldn't go below 3 parts extender to 1 part semen because then you don't have enough of the good stuff in the extender to support the lifespan of those sperm. I'm just going to put this here. If you're interested in doing the math, you can copy it. I can send it to you if you want, but basically this is how I do my math to process the semen. So if you have any questions about that, feel free to ask, but I don't think it's helpful for me to just read off the equations to you. And then finally, once you get it all processed, you can package it. The Equitainer is sort of the gold standard. It maintains its temperature the best over 2 days. And you can pack it in like a Whirl-Pack bag. People really like these disposable shippers now because it's packed in the syringe and it's ready to go, so people don't have to fiddle with it. I will say it's a disposable shipper. It's meant to be used 1 time, but sometimes we see people using them like 20 or 30 times. It's not going to maintain its temperature if you're using it too many times. There was a study that was done a few years ago that showed you could use them up to 5 times without degrading their cooling ability. So just put a mark on it so that you can tell how many times it's been used, and then you won't overuse it. Also, if you're reusing them, it sort of defeats the purpose, which is that you don't have to ship the container, which is the whole reason people started using the disposable containers in the first place, is that they didn't want to pay return freight on the Equitainers. So if you're going to reuse it, just get an Equitainer. All right. So that's the basics of how to do it. There's a few things that we keep in mind to kind of maximize our fertility rates and our success rates. Starting at the very beginning with the collection process. First thing that you want to do to maximize the quality of your sample is going to be a clean out collection. So the sperm is produced in the testis. It then is held in the epididymis until the stallion ejaculates. And if it's held there too long, it starts to degrade. So you can see in this image here that this has a lot of like dead, see all these circled ones, and there's more in there too. Those are detached heads of dead sperm. They've just been sitting so long, they're starting to break apart. And that's not unusual to find in these stallions that have, that's the first collection of the year. So you're going to get better quality if you clean them out and then do your actual collection for shipment, a few days later. You want to collect no more than every other day, because then your sperm count is going to be too low. You're going to exhaust those reserves and have a lower sperm count. But obviously you want to do it frequently enough that you're not getting a buildup. And this is an image of a stallion that had so much buildup, he actually got a plug that prevented the semen from coming out when he tried to ejaculate. Okay, sperm count, maximizing sperm count. So Dr. Gosselin talked about lighting. It's also important for stallions. So you can see in this graph that by month, this is sperm production by month, you can see that it peaks around June and then it starts to decline again. It's because stallions are also long day breeders. They're meant to service the mare in the season. And so if we're going to be breeding these stallions in February or March, then you want to put them under lighting too, so that they can maximize their sperm production. And you can see on this blue line, this is a stallion that's been advanced in his season to maximize sperm production earlier in the season. The other thing is going to be stallion housing. So in nature, stallions, usually there's a harem stallion who's the boss, and then the other ones who don't win the fight, they're the bachelor stallions and they don't get to breed. Those stallions have much lower testosterone levels. This graph is showing you steroid hormones in the feces of wild stallions. And you can see that for the bachelor stallions, they're significantly lower than for the harem stallions. Sperm production is dependent on those hormones, so those bachelor stallions don't produce much sperm. So if you're housing a stallion with a lot of other stallions and he's at the bottom of the totem pole, he's not going to be producing maximum sperm production rates. And then for maximizing motility, Supplements, we've had some really great success with the supplements. You should all talk to Megan over there because she has some great stuff that's worked really well for us. The alpha lipoic acid and the omega-3 fatty acids can really help stabilize those membranes and have stallions that don't cool very well cool much better. The extenders we already talked about. And then the last thing that you can do to improve motility, which we do quite frequently, is centrifuging. So this is a image of a semen that's been extended, and then at the bottom, this red part here is a cushion. So that provides a surface that the semen can kind of lay against when it's centrifuged. And we just spin it down so that all this heavier semen goes to the bottom. We can take off the fluid off of the top and then resuspend that extender or resuspend the sperm pellet in fresh extender. So here you can see this is after centrifugation, the cushion in this one's clear. But if you can tell where these arrows are, that's the sperm pellet. And the reason we do that, we sort of touched on earlier, is that sperm does not like its own fluid. The fluid is designed to be put in the mare, and it has specific actions on the sperm cell that are designed to, they're designed for, being inside of the mare. That's their purpose. But they're not helpful for sperm cells that are going to be stored for a long period. And some stallions have seminal fluid that's contains more beneficial things in it, and some have less. So some stallions really don't like their seminal fluids. Some stallions are okay with it. And so centrifuging is one way that we can really improve the fertility of some of these stallions. I won't go into health screening because we're out of time.
My name is Lauren Pasch. I am a therogenologist at Rhinebeck Equine, and we are going to talk about pregnancy loss in the mare, which is a huge topic. I am not going to cover everything, but I'm going to try to make this representative of what I see in practice with a lot of your guys' horses and the things that I think are the most relevant here. So we're going to start out just going over some basic facts about pregnancy so that hopefully what I say later makes more sense. So some key features of equine pregnancy. The first is the length of gestation, which is long. So 11 months, like I think everybody can agree on that. 11 months or 340 days is the average. There's a whole lot of variation though, sort of within that. I would say anywhere from 320 or 330. We have some mares that'll go up to 400 days, but 340 is your average. The other thing I want to mention is the timing of implantation. So the equine pregnancy doesn't technically implant in the uterus the way that other species do, like humans. So instead, the embryo relies on nourishment from the endometrial glands within the uterus, which produce a uterine milk that we call histotroph. And it depends, so the early conceptus depends on that nourishment for survival until about day 40 to 42, when there is actually an implantation-like event. And that's when the fetal tissue actually invades the maternal tissue to form the endometrial cups. Placentation starts then. And also want to mention, and I will talk more about the type of placentation in a few slides here, but it's a very inefficient type of placenta that the horse has. And development of that placenta continues until about 4 months of pregnancy. And that's when maximum communication between the fetal and maternal tissue is achieved. But we'll talk a little bit more about placental structure. Another special feature of equine pregnancy is the maternal recognition of pregnancy. So how that conceptus or embryo signals to the uterus that it's there. In horses, that early embryo migrates throughout the entire uterus until about day 17 post-ovulation. So this is just showing the time it spends just bebopping around in here. So this movement through signals we don't totally understand prevents the uterus from releasing prostaglandin that would lyse the CL, that corpus luteum, and terminate the pregnancy and bring the mare back into heat. Progesterone sources, and I guess technically it's progestogen sources because in later pregnancy, it's not actually progesterone itself, it's the metabolites of progesterone that are produced. But there are quite a few overlapping sources throughout gestation to make sure that levels are adequate for the whole time. Importantly, and if you look at the little arrow here at 40 days, this is highlighting this because the only progesterone source prior to about 40 days is that primary corpus luteum that forms from the ovulation that led to the pregnancy. Once the endometrial cups form, they produce ECG, which stimulates more follicles to luteinize. And so there's a big boost in progesterone production after day 40. And then from about 100 days on, the fetal placental unit, so both the fetus and the placenta working together, are capable of producing all of the necessary progestogens that are needed for the maintenance of pregnancy. And so progesterone and its metabolites are essential for pregnancy maintenance in every mammalian species. Progesterone allows the placenta to do its job, so specifically nutrient exchange. Progesterone also stimulates the production of histotroph, and that's that uterine milk that the endometrial glands produce to nourish the early embryo. And then progesterone is also really key in maintaining the quiescence of the uterus and preventing myometrial contractions when there is a pregnancy in that uterus. So, since our topic today is pregnancy loss, I'm going to get it out of the way. Primary progesterone deficiency in the mare is a very, very uncommon cause of spontaneous abortion. I'm going to talk more about how progesterone and its levels can impact pregnancy outcome, but primary failure of a CL to produce progesterone is exceptionally rare in horses. All right, so I mentioned the type of placentation present in the mare and that it's quite inefficient. And the big reason for this is that we have 6 layers of separation between the fetal maternal blood supply. So that means basically we have 3 layers on each side. So we have the fetal blood supply inside of this vessel, the maternal blood supply inside of this vessel, and there are 6 layers separating the communication of those 2 circulations. So these 6 layers result in a very inefficient placenta, and this is essentially why twins don't survive. The placenta is too inefficient to support 2 pregnancies. Any disruption of that fetal-maternal interface, which is the placenta, is going to have a significant effect on the placenta's ability to do what it's supposed to do. So this all falls under this very broad blanket term of placental insufficiency. And this is a really key term that I'll come back to later when we're talking about pregnancy loss and placentitis specifically. So this illustration shows microcotyledons. These are basically these little highly vascularized clusters where all of that maternal fetal communication is taking place. They're these highly elaborate invaginations into the endometrium, and this is where we get the 50 to 60 square meter surface area. So the little microcotyledon on the left here shows basically the chorionic villi, so this is the uterine side, or the placental side rather, pulled out of the uterine side, just to give you an idea of an illustration of how many little interdigitations there are. And then the image next to that is an illustration just showing that communication actually happening. So all of which is to say that all of those little microcotyledons are super, super important in making sure the placenta can do what it's supposed to. So we'll move on to pregnancy loss. And I think it's important to keep in mind that some degree of pregnancy loss is inevitable and expected. The vast majority of these losses are going to occur in the first 2 months, but specifically before about 40 to 42 days. And so remember, this is the time where 2 kind of significant things happen. Implantation occurs, and also the primary CL is still that only progesterone source up until that time. So that's a pretty vulnerable time for the pregnancy. There are a whole lot of risk factors associated with increased pregnancy loss, but among the more significant, I would say, is previous abortion or pregnancy loss, advanced maternal age, certainly, any type of systemic pathology or illness, either within the fetus or the mare. And this can be due to both intrinsic and extrinsic factors. All of which to say just being a pregnant mare is kind of a risk factor for pregnancy loss. So this is a chart from the University of Kentucky Veterinary Diagnostic Lab. This is this is their 2023 full crop through January 2nd of 2024. So this is basically 2 years ago data. And I'm just kind of reading what they send with this graph, which is there are typically 400 to 500 cases of fetal and perinatal loss submitted every foaling season. So this data here reflects 188 equine fetuses that were submitted to this lab in Kentucky, and their diagnosis is made on gross necropsy findings, microscopic examination, PCR, virology, some bacteriologic testing. And you can see they have a whole list of causes, but what I really want to point out is that the most common cause in over half of these abortions is an abortion of undetermined cause. It doesn't mean that we shouldn't try and we shouldn't submit things, and there's a lot of things we can rule out, but I think keeping that expectation in mind is helpful. So having just acknowledged that the most common cause is an undetermined cause, these are some of the more common causes of abortion, and specifically, these are the topics we're going to go over today. We'll spend a very brief amount of time on early pregnancy loss, which is going to refer to the first 60 days, so the first 2 months of pregnancy. And those causes of pregnancy loss in that period are quite distinct from the mid to late gestational pregnancy loss causes. So, as we just mentioned earlier, spontaneous luteolysis of that primary CL doesn't really happen. That's not a common cause of pregnancy loss. But remember that that primary CL is super susceptible to destruction from about day 18, which is when there's oxytocin receptor upregulation in the uterus, to day 40, which until then, again, it's still that sole source of progesterone for the pregnancy. So during this time, the CL is pretty susceptible to luteolysis, which if you have maternal illness, that mare is having fevers, endotoxic release, that's going to stimulate prostaglandin release from the uterus, and that can then cause luteolysis. So it's not just a spontaneous loss of progesterone, it is due to maternal illness. A very common cause of early pregnancy loss that's getting a lot of attention right now, largely thanks to the work of Dr. DeMestra at Cornell, is aneuploidy. And so this refers to chromosome misalignment that results in either the gain or the loss of an entire chromosome. So this little schematic here, you can see during one of the divisions that happens within the oocyte, these chromosomes are going to line up on this meiotic spindle, basically, but we have sort of a center line here that they should line up in, and then they should be divided equally like this, where each side, each division gets half of the material. So when there is any sort of error in that alignment and separation, we're likely to end up with aneuploidy. So this is going to be most common in older mares and seems to be more due to issues with maternal gametogenesis, so oocyte development, as opposed to paternal gametogenesis or spermatic development. These chromosomal gains or losses are almost always lethal. So this is a postmortem diagnosis. If you are fortunate enough to be able to actually, between 45 and 60 days, when you check your mares and you notice that there is a non-viable pregnancy within there and you flush it out, these samples can be sent to labs for some genome sequencing to see if we do have an aneuploidy. But this is an area of pregnancy loss is getting a lot of attention right now, and I think there's a lot more work coming on that. But right now we know that it exists. We know there's not a whole lot we can do about it, but hopefully as we learn more, we can work to avoid that. So I'm going to spend the rest of this going over some of the more common causes of late pregnancy loss, some infectious, some are not. Like I said, we're not going to go over everything, but I want to go over cases that represent what we see in this breeding population. Here we have a really excited intern from a few years ago doing a fetal necropsy to try to determine the cause. So umbilical cord torsions are, as I was taught, a diagnosis of exclusion. However, they are a very commonly stated cause of abortion. So it makes sense that if we have a twisted umbilical cord, that's going to compromise the blood supply to the fetus. It also seems logical to me that if we have an exceptionally long cord, it's probably more likely to twist. Short cords are not terribly common. Not every twisted umbilical cord means that that was the cause of abortion. For me, it's a little bit of a chicken-egg situation in that when you have fetal stress for whatever reason, that typically results in a transient hyperactivity. So the fetus is just going to be flailing around within the uterus for a short period of time prior to death, which can cause cord torsions. It's not really significant, I guess, in terms of the fetus is aborted. There is a twisted cord, but it is my impression from seeing a lot of these cases that we can't necessarily say that the cord torsion happened before or after fetal death. And these are pictures from actual cases. So this cord is quite clearly torsed, as all of these are. So you can see that there's more than 5 to 7 twists, which is usually the average number. But more importantly for me, you can see that there's congestion, there's edema, there's that purple color showing that we are not getting adequate blood supply between the fetus and the placenta. And some of these, so this was actually a full-term abortion and led to a dystocia, and this foal was removed under general anesthesia. And this was what we saw as we pulled the foal out. Whether that was the cause of fetal death or not, we couldn't say. There were no other significant findings. This was actually a fetus that I'll show you a picture of another part of its body on the next slide. But this foal had this fetus had a lot of issues, and it seems highly unlikely that this twisted cord was truly the cause of abortion. So it's something to note. It's something we see a lot of. It's something that I think, depending on who you asked, either gets overdiagnosed or not. But I'll just say, just because we see this very twisted cord does not mean that that was the cause of abortion. Congenital anomalies are another cause of mid to late gestation abortion. These are more often going to be fetal anomalies than maternal. So hydrocephalus and fetal monsters are fairly obvious causes. So these are not terribly common conditions. However, when you have a foal or a fetus that presents like this, it's pretty obvious that that was why the abortion happened. There's some maternal congenital issues that can contribute to abortion. Segmental aplasia of the mare's uterus, super uncommon. Hydrops, so basically there's excessive fluid production within the uterus. And we could spend a whole nother hour talking about that, so we won't. But this foal with the messed up face here. So this is the same one with the twisted cord in the last slide rather. And this came out of a mare with hydrops. So there's probably a couple issues that were all intertwined here and sort of playing on each other. But the reason that I was able to say that that twisted cord was not the primary cause of abortion is because the fetus did look like this. All right, placental insufficiency is one of the most common results or findings that you're going to get back if you send in a placenta for histopathologic evaluation. So as I mentioned, placental insufficiency is a really broad term, and it describes the result of any number of issues that interfere with that fetal-maternal interface. So usually placental insufficiency is attributed to placentitis. It can also result from placental thickening, placental separation, all of which go hand in hand with placentitis. And then also angiogenesis dysregulation, so issues with the formation of the appropriate placental vasculature. Placentitis quite literally means inflammation of the placenta, but this reflects a huge number of specific conditions. So ascending placentitis is the most common, and this refers to an infection that ascends through the mare's caudal reproductive tract. Mucoid is typically referring to an accardiform placentitis, where there is placental separation and inflammation at the base of the uterine horns. This is a really specific and kind of seasonal type of bacterial placentitis that thankfully we haven't seen much of in a few years. If we have a diffuse or a multifocal distribution of lesions on the placenta, that's usually going to reflect a hematogenous spread of an infectious agent, so through the vasculature. As far as what infectious agents are to blame, bacterial organisms are by far the most common. Strep is by far the most common of those bacteria. Occasionally we will see leptospira-induced abortion. Nocardiaform, as I mentioned, is the weird mucoid one, and it's very specific organism, so Crossiella equine, Amycolatopsis. And then we will also occasionally see a fungal organism causing placentitis. So this is, in theory, the series of events that lead to an ascending bacterial placentitis. So bacteria are going to breach the caudal reproductive tract. That's certainly going to be more common or expected in a mare that has really poor vulvar conformation, doesn't have a Caslexin, and she should. So that's going to result in, so that bacteria is going to come up through the vulva, through the vagina and the cervix, and then affect the more cranial reproductive tract. Typically, that's going to result in this inflammation. We have a white blood cell infiltration as a result. The placenta thickens, it can separate from the uterus, which causes placental insufficiency. So the fetus isn't getting everything it needs, so it gets stressed. Then that stresses out the uterus. So there's prostaglandin release, which can cause uterine contractions and preterm labor or abortion. Certainly, it doesn't always follow this exact pathway, but this is, in theory, how that would happen. These are some placentitis images. So here on the left, this is sort of our classic ascending placentitis image. So we have the two uterine horns up at the top. And here you can see this line of demarcation. So back here would be the cervix. So this was very representative of an ascending placentitis where it traveled up through the mare's cervix and affected the back part of the placenta first. So this entire area represents where there is significant placental insufficiency, because that is going to be unable to communicate with the uterus the way that it's designed to. The image in the middle here, this is a bit of a non-specific finding that we often see with abortion, but this is a meconium-stained amniotic membrane. So this should be clear, translucent, kind of whitish. And when you have this really bright kind of yellow, mustardy color, that's representative of fetal stress. And then this last image shows the classic nocardiaform placentitis lesion. So you can see we have the tips of our horns here, the uterine body, and the cervix back here. And so at these horn bases, this is where there was placental separation and a whole ton of this mucoid discharge, kind of muddy, peanut buttery almost. And so that's going to interfere with the placenta and the uterus communicating. So mares with placentitis are almost always systemically normal. If we do see external clinical signs, it's typically going to be premature udder development and or vulvar discharge. But these are not usually mares that tell us they have a placentitis because they're systemically ill. They don't typically have a fever. Their systemic blood work and white blood cell count is typically going to be normal. So you may not catch placentitis early unless you are doing an ultrasound exam. So, as I just said, given that these mares are systemically normal, diagnosing placentitis is often based on ultrasound exam. So this exam involves transrectal palpation, specifically for assessment of the uterine tone and the cervical competency. So these are more subjective findings, as well as transrectal ultrasound. And certainly we should look at and measure the mare's CTUP, which is the combined thickness of the uterus and placenta. And you can see that in the image on the left here. So the brighter white line that's right above my little cursor is the endometrium. So that's the mare's uterus. And then the more gray line on the other side of that is the placenta. And there are good numbers of where we expect that thickness to be at different stages of pregnancy. An increasing thickness is indicative of inflammation, and in some cases, placentitis. So the CTUP is not the be-all, end-all, though. It's important that when we're doing this ultrasound exam, we're also looking at the character of the fetal fluid. It should be fairly anechoic, black, not terribly cellular. We want to look at the thickness of the amniotic membrane, so not just that outer layer of the placenta, but the inner one as well. And then the presence of any fluid in the vagina or fluid causing placental separation. So this image on the right, this mare had absolutely no clinical signs. So this was a routine 8 to 9 month ultrasound exam, and we found significant placental separation. So here, this is the uterus, and here's the placenta way over here. So they should be touching as they are in this image. So this entire area of separation is useless placenta. So this is another way that we get placental insufficiency, because that fluid is preventing the endometrium and the chorioallantois from communicating and sharing their blood supply. Hormone assays can be used to support a diagnosis of placentitis and also get a sense of the degree of fetal compromise. So we look at the total estrogens and the total progesterones or progestogens, as these reflect both the fetal health and the placental health. There's huge ranges that are still characterized as normal for different stages of gestation, but it's something that you can measure, see what your numbers are, and then after you've treated the mare for a month, you can recheck those hormone values and use that as a marker of how successful your treatment has been. Classic placentitis treatment involves kind of throwing everything we can at this mare. So the hallmarks are going to be anti-inflammatories, whether that's Banamine or usually I personally will end up using Equiox. We know that that crosses the placental barrier very well. Antimicrobials to combat the presumed bacterial cause of the placentitis. Usually these mares are being supplemented with Altrenagest or progesterone just to make sure that the cervix is staying as tight as it can and the uterus is staying quiet and not contracting. And then a rheological agent, so pentoxifylline, and this is going to help improve blood flow so that we can maximize the communication in those microcotyledons that are still working when we know we have quite a few that are not. All right, so moving on from placentitis, equine herpes virus is another cause of abortion, mid to late gestation, ultimately causes placental insufficiency, and that is why fetal death results. The most common means of transmission is respiratory, and typically the virus is shed for about 1 to 2 weeks. There can also be transplacental transmission, so that's a vertical transmission from the pregnant mare to the fetus. If this happens in very late gestation, sometimes you will have a diseased live foal, but typically this causes abortion. And that transplacental transmission is much more common with EHV1 than EHV4. But with either form of transmission, the abortion is due to a cell-associated viremia. So what happens is there's inflammation of the blood vessels, including all of those blood vessels within the endometrium and within the placenta, and they're going to have infarctions where they cannot continue to have blood flow and circulation. So just remembering how essential every little microcotyledon is for maintaining placental function. When you have interruption and death, or not death, but ineffectiveness of these microcotyledons, you have placental insufficiency. One very special thing about equine herpes virus and all herpes viruses is its latency. So this refers to an inactive reservoir that exists in the horse, in the lymph nodes or in the trigeminal ganglion, and it's activated and can cause infection. This is kind of a hallmark of herpes. Herpes is forever. This is a really nice illustration sort of explaining how herpes works. This is from the horse. But we can have a horse that is latently infected, so they have that inactive dormant reservoir hanging out. There's a stressful event, and all of a sudden the virus is activated and they're shedding. So another horse can become infected, and the cycle continues. And then this image here, it's just sort of illustrating that the virus is going to hang out in these specific sites, specifically lymph nodes, and from there can travel into the bloodstream. And then when we're talking about EHV1, it's going to have a predilection for traveling to the uterus and causing abortion, or the nervous system or spinal cord and causing the neurologic form of EHV1. So unfortunately, herpes abortion is rarely preceded by clinical signs, and it tends to occur in that 7 to 11 month gestational range, so certainly the second half of pregnancy. Because of the pathogenesis of the virus, that it causes these microcotyledonary infarctions and then the placental insufficiency, this disease did not cause abortion before 5 months of pregnancy. If you remember at the beginning, I mentioned that placenta is still growing and developing up through 4 months. So in order for those microcotyledons to be established and fully functional so that their injury is significant, 5 months is usually the earliest we see this type of abortion. It's important to note there's no adverse effect on the future fertility of the mare following a herpes abortion. And that's all I'm going to say about that. So prevention and control is really about reducing aerosol transmission and having good biosecurity on your farm. The respiratory form of transmission is by far the most common. We do have vaccines that are specifically designed to help prevent abortion as a result of EHV1 infection. So this is going to be either Pneumabort or Prodigy. These are not the same vaccines as Rhinomune or a flu rhino or anything that is really just targeting the respiratory form of the equine herpes viruses. So again, keeping in mind the time of gestation, when we see loss from herpes, we want to vaccinate these mares at 5, 7, and 9 months. Some people like to start at 3, which isn't wrong, but based on the sort of physiology and the way that the virus affects the placenta, 5 months is adequate to start treating. Diagnosis is usually based on PCR of various fetal specimens that your veterinarian can collect, as well as placental specimens. So the next infectious cause that I want to mention is a neorickettsial abortion. This is due to the causative agent in Potomac horse fever. So pregnant mares who have Potomac and they recover, they've survived their fevers, they've stayed pregnant throughout all of that, they're not out of the woods, unfortunately. And so if these mares do go on to abort, usually within about 3 months after recovering from the initial illness, ideally we would be submitting fetal samples for a definitive diagnosis, which is PCR of the fetus. And that's sort of how we have figured out that there is this delayed abortion after mares have suffered Potomac. Not anything you're going to do about it, but it's something I think to keep in mind if your mare has Potomac horse fever, maintains her pregnancy and gets through it, and then does go on to abort later on, consider testing for those organisms. And then the last thing I'm going to talk about is equine arteritis virus. So EVA, it's a single-stranded RNA virus. It has quite a few routes of transmission. Respiratory is going to be much like herpes, what we're most concerned with here in terms of biosecurity on a farm. And an acutely infected horse is going to shed for up to 2 weeks typically. Venereal transmission is probably what most people in this room think about when they think of EVA, because we are testing stallions to see if they have a titer before we allow them to breed mares. Venereal transmission, however, is not going to cause abortion, mainly because these mares aren't pregnant if they're being bred. So you're not going to get direct abortion of a mare who's not pregnant. However, a naive mare can be infected and then shed the virus and then cause a spread. So just a few more things about the venereal transmission. This is only associated with stallions. They are asymptomatic, but they, kind of like the herpes virus, having a latency in a reservoir. There is an androgen dependent, so testosterone dependent carrier state where stallions can just hang out with EVA in the reproductive tract. They're not febrile, they are not clinically ill at all, but they can transmit it then to mares. And this virus does survive freezing and the cooling of semen. So any equipment that's used in conjunction with collecting or breeding stallions that are EVA positive is a potential mode of transmission. And then the last means of transmission is transplacental. Again, that vertical transmission from an infected mare to the fetus. So the incidence of abortion falls into a huge range depending on where you look. So that's not super helpful. But in contrast to a herpes virus abortion, these mares are more likely to be systemically ill. Not always, but certainly more likely. The abortion pathogenesis isn't very well understood, but it's similar to herpes in that it results in a vasculitis, which can lead to placental insufficiency. Abortion diagnostics, we're typically doing PCR, once again, on various fetal tissues and placenta as well. So prevention and control are really key with EVA. Keeping in mind that there is a natural reservoir in some stallions, we want to do our best to ensure that the stallions on our farms are not, in fact, carrying EVA. And so stallions should be tested to ensure they have a negative titer prior to vaccination. The vaccine that we use is a modified live, so this is not something we want to use in pregnant mares. I personally don't recommend routine vaccination of mares for this because our stallion population is going to be at the heart of causing any sort of spread. So it's really about managing your stallion population. And this is just one of those diseases I personally don't see it causing abortion often, but it's something we always want to test for because it's infectious and it can affect the fertility and the health of the entire farm. So how can we minimize pregnancy loss? Well, in really broad strokes, keeping general health at the forefront of your mind, making sure that these pregnant mares are having routine, good health in terms of diet, making sure we're up to date on vaccinations, which are almost never going to completely prevent disease, but they're going to reduce the incidence, they're going to reduce the severity of clinical signs. And then maintaining good biosecurity is key as well, knowing that there's a lot of respiratory transmission of viruses in particular. And if your mare does abort, I did say that very rarely are these mares clinically ill, but it's always good to take your mare's temperature. If it's feasible on your farm, the safest thing to do is to isolate a mare after she is aborted. You always want to save the fetus and placenta and call your veterinarian. There's a lot of information we can get from looking at the mare, looking at her placenta and the fetus, even if we decide not to send out samples for testing. There's quite a bit of information you can get just from a gross examination. And that's all I have. This was a highly abnormal placenta. It was very inefficient, but huge. And we will take questions later on as part of the panel.
So today I'm going to talk about acupuncture specifically for the Cryptorchid, but I'll go into acupuncture as a whole to kind of open up the stage for that. First, can I get a quick show of hands of anybody that has used acupuncture in a horse before or has considered it? Okay, a handful. I'd love for there to be more hands up there in the next year or so. Acupuncture is actually super helpful for reproductive problems. Quick introduction of myself. I am not a specialist. I'm an ambulatory veterinarian at Oakencroft. I practice equine chiropractic as well as acupuncture. And that's my mare who someday might have a child. So what is acupuncture? Acupuncture is a part of Chinese medicine, which has been around for thousands of years. I say a part because Chinese medicine is kind of all encompassing. It is very, very deep in how we practice, Chinese medicine. So it's not just acupuncture, and we'll touch base with a couple of the other modalities in true TCM. Acupuncture focuses on adjusting discrepancies with energy flow within the body. And this is on a precedence that the body is equipped with its own energy that can provide healing mechanisms and overall health. And we're just here to say, hey, remember this spot? You need to focus on healing there. Acupuncture utilizes points along 12 main energy channels. And for the most part, these channels are called meridians. And for the most part, there are 12 on the right side and 12 on the left side of the body. There's a couple that are only in one spot, but there are hundreds of points that we can hit on these guys to help them wake up their own immune system and get their energy flowing. This chart shows several of them, but it's not even half of the points, I think, are on that chart. Acupuncture uses a method to stimulate an acupuncture point along the meridians that I just showed. You can stimulate that point in a multitude of different ways. So if you have an animal that is needle resistant, have no fear, there's options for them. Typically, when we think of this modality, though, we do think of needles. And if you could see here a comparison of sizes of small things that we have in the world, this is a match. It is 4.5 millimeters, I think that says. And then we have a typical hypodermic needle, another type of needle, a sewing needle. And then below that even is the acupuncture needle, which is 1/4 of a millimeter. You can hardly see it. Some horses still feel it though, and they'll let you know. Those horses that don't allow you to put a needle into an acupuncture point, you can use heat, you can use pressure. The ones that do allow injections, you can even ramp it up by injecting B12 or blood into the acupuncture point. We also combine needle acupuncture with other Eastern medical modalities to increase the efficacy of the treatment. We can do that with food therapy, herbal therapy, and also something called Tyma, which is a way to manipulate acupuncture points with your hands. Okay, so bear with me. We're going to dive into some Chinese medicine here. You all probably know of yin and yang, yin and yang, if you learn it the Chinese way. This symbol here of the black and white. The Chinese medical exam starts here. So yin has a whole meaning and yang has a meaning. For every yin, there is a yang. And to kind of explain that a little bit better here, on the left side of the screen, I've got all yin characteristics, and on the right are all yang characteristics. So yin is associated with nighttime or darkness, the moon, cold, winter, very yin outside right now. Something that's heavy, slow moving. If you're talking about a viscous, it could be the inside of a viscous versus the outside, which is yang. Ventral or the abdomen of a horse, posterior or the back end, death, backwards, and also weakness. Yang is the complete opposite of that list. So daytime, the sun is shining, it's warm, so summer is very yang, something that is light in weight, fast in speed, the outside of a viscous, the back of an animal, anterior or their head. It's associated with birth, moving forward, and strength. The next part of our Chinese medical exam is looking at the tongue of the creature that we're examining. This is our Jack Russell. His tongue is always out, so it's a good example. He has a beautiful tongue. It is peach pink. It is the appropriate size for his mouth. The edges are nice and sharp. It's not swollen. It's not overly red. It's not pale. Looking at the shape, color, and texture of our patient's tongue can tell us a whole lot about what the energy of their body is doing. If their tongue is pale, they're dealing with a deficiency. If their tongue is bright red, they might have an excess pattern that we need to treat. Next, your veterinarian is going to assess pulse quality. Pulse quality, they look at the depth, strength, and position of the pulse. In horses, it's felt at the thoracic inlet or the lower neck, just before the shoulder. Your veterinarian is going to feel it on both the left side and the right side because it tells you something different on each side. remembering that one side of the horse is yin and one side of the horse is yang. Left is yin, right is yang. In dogs and cats, they'll use the femoral artery, and in humans, if you go get acupuncture yourself, they use your wrist here, and again, they palpate both sides. To assess pulse quality, it's just a very soft 3-finger touch, and each finger position is associated with something different in the Chinese medical world. So each finger, even though you're over the same vessel, which might not jive with some of our sciencey brains, each finger means something different. So when you feel that it's weaker on your 3rd finger, that might mean the kidneys are deficient, for example. Okay, this is the fun part, so I always include it. Constitution of the animal or the patient is very important. So on the left-hand side here, I have 5 constitutions, the 5 Chinese medical constitutions that we classify everything into. On the far right-hand side, I've got some breeds, horses, and dogs that compare to those constitutions. I have also provided you all that have attended in person a sheet so you can play with this and figure out what constitution you are, or your dog or your horse. And on that sheet, it also goes into, you know, a wood animal. When they're balanced, they're competitive, confident, assertive, strong, athletic. It's that Jack Russell I showed you. But when their energy is unbalanced, they tend to have tendon and ligament problems. They might have liver disease. They can have red, teary, watery eyes, or have nail or hoof problems. So it can kind of help you look at the constitution of your animal and what problems they might see down the road if their energy gets quote unquote stuck. I'm not going to go through all of these because it's pretty wordy, but for those of you that are attending online, we're also going to email you this form so you can play with it as well. So since this is my favorite thing, we're going to go through my animals quick. On the left, that's a draft horse. He is an easy keeper. He is a lovely dude. He just wants to be in your pocket. He is earth. Because he's earthy, he will likely have a hard time with his digestive tract down the road. In the middle, we have a metal creature. She is part border collie. She needs rules. She needs her dinner at 6 o'clock or sometimes 5:45 if her clock is off. She tends to have arthritis and dry skin, which runs along with metal. Miss Princess on the right is a water creature. That means she's afraid of everything. That comes with kidney disease and also, well, hopefully not kidney disease for her, but hind end weakness, which she for sure has. Another earth, wood, fire. We talked about these guys a little bit, so we don't need to go into them too much, but they're cute, so they're there. So this is why that becomes very important and why I waste any time talking about it. The 5-element theory. In Chinese medicine, it is vast. We look at all sorts of aspects of the patient that we wouldn't normally look at in a Western medical examination. So the 5-element theory puts all of these animals and their constitutions in a circle where they communicate with each other. So imagine here between fire and earth, there's an arrow pointing to earth, and then an arrow pointing to metal, and then an arrow pointing to water. So fire feeds earth. The heart feeds the spleen feeds the lung, and it goes all the way around. Everything in Chinese medicine is connected. Likewise, you can kind of crisscross across this circle. Fire has it's called a grandparent role to metal. So if metal is deficient, it pulls from fire as well. Things are incredibly complicated and complex in the Chinese medical world. So that's just a very small introduction to it so you can understand what we're about to look at. This is an example of how complex it gets. It's a very similar diagram of the 5-element theory. This is what your acupuncturist is going to use to help pick points. It's depicting the same thing with a few extra details. Okay, so Jing, this is very important. Jing is essence. It is the energy that you are either born with or the energy that you are acquiring over your lifetime. Prenatal Jing or Yin Jing, Yin because it's prenatal, Yin is dark, you're in a womb. Prenatal Jing is acquired from the mother and the father. It is similar to DNA in the Western medical world. And you're born with a certain supply of this stuff. You can't get any more once you hit this planet. So what you got is what you got. And then you move into postnatal Jing or Yang Jing because you are in the world where there's sunlight. Once you're born, we've entered the Yang part of your life. This is acquired after birth through good nutrition, water, oxygen, the environment that you're dealt. There's a fluid supply of this stuff, so you can use it up and go get some more. If you take care of yourself, you can also use it up and deplete what you've got if you're not taking care of yourself. So energetically, what happens at birth? The fetus is expelled from the largely yin womb and introduced to the world of yang. Prenatal Jing level is set, and this is when you can start acquiring postnatal Jing. Again, good quality feed, the environment that you're in, all very important. Jing is used to jumpstart life processes, so breathing, digestion, growth, maturation, all of the steps that a neonate goes through as it grows. So, cryptorchids, which is what we're here to talk about today. In the Western medicine world, a cryptorchid is a visibly or palpably, or an animal that's visibly or palpably lacking one or both scrotal testicles. It is thought that this is highly genetic, but can be hormonal and have mechanical factors as well. The word broken down simply means hidden testis. So crypt means hidden and orchid means testis. It can be bilateral or unilateral, so you can feel one or no testicles in the scrotum. The bilateral cryptorchids are usually completely sterile because the sperm needs a certain temperature in order to be viable, and it will not be viable inside the body cavity. It's helpful to note that testicles embryologically originate up by the kidneys, which I'll show you on a diagram on the next slide, and eventually slowly make their way down through the inguinal canal and drop into the scrotum. Why do we care about this? Why do we care if our colts have testicles that we can see? Why do we care if our stallions have testicles that we can see? Well, for the obvious reasons. If we want a breeding stallion, we need their testicles to produce sperm. So if they're up in the abdomen, that's not going to happen. But also, we don't want to run into unknown elevated testosterone levels, which leads to behavioral issues that not everybody's equipped to deal with. So this is a diagram just to show you, it's about vessels, which I don't care about right now, but what we do care about is the kidneys up here and the scrotum's down here. So those things have a long way to travel before they get to where they're going. And sometimes they need a little help. So in the Eastern medical world, a cryptorchid typically shows a weak pulse in the third finger digit or in the third finger position, which is where the kidneys communicate. Again, kidneys are where they start from, kidney energy, very important for these guys. We typically see a tongue that is pale, showing a deficiency, and also small, potentially showing that they have not enough prenatal Jing. This tongue has a lot of issues, but I put it on there because it is kind of small for that muzzle. It looks a little bit pale as well, and it's very bilobed. The diagnosis in the Chinese medical world, typically for a cryptorchid animal, is prenatal Jing deficiency and also kidney Jing and Qi deficiency. So how do we treat these guys? The main thing is you want to start as early as possible in the 6 to 12 month range. If you don't see 2 testicles, or if you only, they're there intermittently, it would be wise to start talking to your veterinarian right around 6 months. I have personally had success treating these guys as late as 3 years old, but that was a little bit of acupuncture and a little bit of a prayer at the same time. The integrative approach is very important. Do not discount the Western medical side of things. We should ultrasound these guys and see where they're located. We can also use hormone therapy with HCG. A couple rounds of that will help your acupuncture as well. We can actually use HCG in acupuncture points to increase the efficacy of all of those treatments together, or we can give HCG IM over the course of a couple weeks. And then, of course, acupuncture, it's important to perform a complete Chinese medical exam, not just walk in there and say, oh, this is a cryptorchid. We're going to throw needles in points X, Y, and Z and wipe our hands clean and walk out. It's really important to know what's going on with that animal energetically. We're going to go through that whole exam that I explained to you and choose points based on that patient today, the diagnosis today, and their constitution today. Their constitution can change too. We're also going to choose some of those points based on the known problem. We're out there for a cryptorchid. Those XYZ points are going to be in the back of our mind. And together, we're going to make a really strong treatment protocol for these guys. I listed a couple points there, but that probably makes no sense to anybody. Shen series, byway, some of the bladder meridian, kidney, and gallbladder. So moving along with the treatment for these guys, acupuncture needles can be hooked up to electroacupuncture units, which is what's shown in the picture here, if they allow. Again, we're working on young animals, so sometimes we can't jump into electro. But what this does is it increases the amount of stimulation at the point that we're using. And we can also choose specific frequencies. We can hook our electroacupuncture to different areas to encourage energy to go in a certain direction. I tend to like sending energy down their spine and straight down to their scrotum. They handle it pretty well, shockingly. This picture is of a 2-year-old I was working on. Typically, these guys need several treatments to encourage everything to move. If you think about it, we're moving something physical. That's going to take time. So repeat treatments are important. In the beginning, usually every 5 to 7 days, depending on how they respond, and then you can bump it out, decrease the frequency, go every 2 to 4 weeks as needed. I also really like to add herbal therapy for these guys. It increases the effectiveness of our treatment. There's 2 good formulas for these little dudes. One is epimedium powder and the other is testicle formula. These, again, this is herbal formulations, very Chinese in origin, but talk to your acupuncturist if you're interested. It would be silly of me to not mention the other things that acupuncture can do for your creatures because it is vast and it helps pretty much everything. Mares in particular, it can help with an irregular estrus cycle, delayed uterine clearance, uterine infection, early embryonic death, dystocia, age-related difficulties getting pregnant, and also body soreness and overall comfort while they're carrying a baby to term. If you back up a little bit and think about Chinese medicine as a whole, essentially, we're just going to help them move their energy appropriately and get through any difficulties that they're facing through their pregnancy. Whoops. For stallions, it can help with poor semen quality, poor libido, retained testicle, which we just talked about, again, body soreness and overall comfort. Foals, super helpful for a dummy foal, a foal that's colicking, overall shows hind end weakness or full body weakness. It's great in conjugation with Western medicine if hospitalized for a more serious ailment as well. All right, that's all I got for you guys. I just wanted to thank our sponsors again for making this event possible.
Hi, everybody. So I'm Chrissie Schneider. Like Dr. Jevzika said, I work for Merck Animal Health. I'm one of their equine professional services veterinarians, and I live in Ohio, originally from Massachusetts, so it's always fun to be in the Northeast. And I'm super excited that my current gig gives me the opportunity to come and do things like this, and hopefully give you guys some information. I think a lot of this stuff will be review, but maybe something that you haven't actually like sat down and thought about for a while. You know, we talked about colostrum earlier, and I think everybody knows how important that is and why, but I think hopefully it'll be useful for you guys to kind of revisit this and get some more details. Okay, so we're going to talk about maternal antibodies. First, kind of back up, what is an antibody just in general? It's a protein, so all antibodies are proteins produced by the immune system in response to the presence of a foreign substance. So we call whatever foreign substance we're talking about an antigen. There are bazillions of antigens in the world, some of which we can vaccinate against, which we're going to talk about. So antibodies recognize and then ideally neutralize specific antigens, protecting the body from infections. So an important word in that sentence was specific. So antibodies are very specific to a specific antigen. So if you have antibodies against this antigen, it does nothing for this antigen. There are other parts of the immune system that are more broad and protect against lots of different types of things, but antibodies are not one of those. So this is just a little schematic of, a cartoon of an antibody attaching to an antigen. And so once it's attached, then it can kind of let the rest of the immune system know, like, we have an invader, we need to do something about this. So we also are hopefully going to, at least for all the antigens that we can, give our animals and us as people their first exposure to a disease or to an antigen via something like a vaccine, which is not going to cause the disease, but it's going to give that immune system the chance to make antibodies so that they're ready and waiting in the wings if and when they are exposed to that antigen in the real world. Okay, so maternal antibodies specifically are passed from the mare to the foal through colostrum. Now, in order for this to happen, a mare has to be fully vaccinated, ideally before they are bred. So they need to go through the initial vaccine history. So if you get a mare that does not have a vaccination history, and I think everyone would agree, hopefully, that on a piece of paper saying fully vaccinated is not a vaccination history, right? Because what does that mean? Nobody knows. So if you get that, just in my opinion, assume that the mare is unvaccinated and just do an initial series so that you know what that mare has been vaccinated against. And then once you have a fully vaccinated mare, she's bred, you've come up to 4 to 6 weeks prior to foaling, then we're going to give our pre-foaling boosters so that we're going to create the best quality colostrum. Well, one aspect of making great quality colostrum is doing those pre-foaling vaccines. And as we talked about earlier, that foal then has to ingest that colostrum that you've gone to all the trouble of making as robust and strong as possible. And they have to ingest that colostrum within the first 24 hours of life, right? So I know I'm preaching to the choir the importance of that, but there are lots of pieces and parts. Now, when I'm going to be talking about maternal antibodies and interference and things like that, I mean from colostrum, that's kind of ideal way that our foal is getting these maternal antibodies, but also I mean via plasma. If colostrum doesn't happen and we're outside of that window when we're giving plasma, same kind of things go for those antibodies as well. Okay, so these maternal antibodies, as we've already covered, essential for protecting a foal from disease early in life. They are born naive, meaning they have zero protection, really from anything. They have an innate immune system, thankfully, but they have no antibodies to anything. So they need to get everything from these maternal antibodies via colostrum or plasma. And at the same time that they are essential, they also can cause some trouble when we're talking about kind of ramping up a foal's own protection from their own antibodies, because these maternal antibodies can interfere with that foal's own immune response to vaccination. So it's just something we need to keep in mind. There's nothing we can do about that. We can't change this. We just have to work with it. So maternal antibodies do this in kind of 2 different ways. They can block the receptor that's responsible for initiating that foal's immune cell response, or they can kind of get in the way by covering up the part of, for example, a vaccine meant to stimulate a foal's immune response, basically saying like, I got it, you don't need to deal with this, when we are actually trying to get the foal's immune system to deal with whatever, this vaccine. So as a little disclaimer, this graph is completely schematic, so the numbers mean nothing. I literally just put like 852, like the numbers mean nothing. But I put this in here, and we're going to see this a little bit later, as basically just the overall theory. I think it's helpful to see visually that this dark green line is the maternal antibody that is degrading over time because they're proteins, right? They don't last forever. Which is why we need to get the foal's immune system to make their own antibodies. But so maternal antibodies declining over time, and then we're going to vaccinate our foals. In this example, we're going to start vaccinating at 4 months of age. And so then you can see that lighter green line starting to come up. So this is just a visual of this theory. So we are going to vaccinate our foals, but it is important that these foals are properly timed, or the vaccines, excuse me, are properly timed, and that the initial vaccination series is complete. And we're going to get into what that means here in a second. But this is important for, of course, the health of the foal in the immediate time, short term, but also it allows us or gives us the expected response to future vaccinations for the rest of that horse's life. So that initial vaccination history or vaccination series when a foal is young is really important kind of for its lifelong health. No pressure, right? So when we're making decisions on what we're going to vaccinate a foal for, we certainly don't have time to go through, all the different vaccines available. We're just going to touch on this, but there's not a one size fits all. Every foal in every part of the country should be vaccinated against the same things at the same times. So we choose based on the risk of exposure to a particular disease in your area of the world, the consequence of that disease, how bad would it be if the foal or horse, contracted this disease, how well the vaccine works. So not every vaccine has the same efficacy. For example, rabies and tetanus, we expect really sterile immunity. If an animal is appropriately vaccinated against those diseases, we do not expect to see those diseases in those animals. And that's not the case for every kind of vaccine. The cost of vaccination versus the cost of the disease, and then of course the potential for adverse reaction in individual animals. So resources for making these choices, absolutely your number one is your local veterinarian. No surprise there. They are the people that are involved, in your farm care. They know what you do with your horses, your travels, your geographical area, of course. And then there's another resource that I think can be really useful, and it's free to the public. The AAEP has a great website. They have a lot of resources on that website that are free and public. You don't have to be a member of the AAEP. And one of those things is a vaccination guideline. Now, there are two guidelines available. There's the adult vaccine guideline and the foal vaccine guideline. So just make sure you're looking at the right one, depending on what you're looking for. And so AAEP splits all the vaccines that are available in the US into two different groups. So there's the vaccines that all horses and donkeys and mules, so it should say equids really, but so all equids in the US should be vaccinated against Eastern equine encephalitis, Western equine encephalitis, West Nile virus, tetanus, and rabies. And then you'll see there's quite the list of risk-based vaccines available in the US. I've highlighted or kind of bolded the most common ones that are given. So rhino, EHV 1 and 4, influenza, botulism, and Potomac horse fever. I probably could have bolded strangles too, but. So back to this initial vaccination series, that's very important. Young horses need 3 doses of vaccine for Eastern, Western, West Nile, tetanus, flu, and rhino. So of the most common ones that are given, rabies is not listed there. Rabies has some different requirements that obviously your veterinarian can guide you in. But for all of these vaccines, they need 3 doses. Their first dose should be when they are 4 to 6 months of age. And I should say that this is kind of general guideline. Of course, depending on the risk of your farm and where you are, it might change. But according to the AAEP, this is kind of the blanket guideline. So first dose at 4 to 6 months of age, second dose 4 to 6 weeks after that first dose, and then a third dose at 10 to 12 months of age, then once a year thereafter. Now, this third dose at 10 to 12 months of age, I am bolding, and I'm going to make a whole nother slide about it because this third dose at 10 to 12 months of age is sometimes the one that is missed or mistimed. I think we're all pretty good at getting those first 2 doses in 4 to 6 weeks apart. But this third dose can get tricky, especially if you have lots of different foals born at different times at your farm, because this really needs to be based on the foaling date for each foal, not when, all the foals are vaccinated at one time, or, it can be tempting to try and time it with, when your adult horses are getting vaccinated in spring or fall. Sometimes it might work. I got 2 examples here I'm going to show you. Sometimes that might work, but sometimes it might not. And it's important enough to have another visit by your veterinarian to make sure that each foal gets the vaccine when they should get it. So for example, if you have a foal that's born in February, then you want to vaccinate, if we're going to do it 4 months, this is just an example, June, July, and then sometime between December and February is going to be that 10 to 12 months of age for that foal. You're probably not vaccinating many other horses in that time frame, maybe for, pregnant mares getting their rhino, but still needs to be done, right? Versus if you have a foal that's born in May, then we're going to vaccinate if we're starting at 4 months of age, September, October, and then March to May, which might work out if that's, when you're going to be doing your spring vaccines for the rest of your farm. Okay, and I can't talk about vaccines and foals without talking about biosecurity. I feel like Dr. Jevzikas will be happy about this. So, vaccines are really important. They help us in many ways and protect our animals, and they cannot replace or overcome poor biosecurity and hygiene practices. Here's our graph again that we saw earlier in the presentation, and I'm going to show you kind of two different examples. So what I am hoping to convey is that not only are we not vaccinating against every disease that a foal can get, right? There are many diseases that we don't have vaccines for. So that is a reason for biosecurity. But also, even for those diseases that we do have vaccines for, we don't protect that foal every minute of its life, right? So here's an example. We have our green line, that's the maternal antibodies that are declining. And then we have our light green line, that's our foal antibodies that are coming up, right, after we started vaccinating. So if we arbitrarily pick the number 4, so below 4, they are not protected, right? Above 4, arbitrary, they are protected in this example, right? Then we have this window of time where we are below that protection time. And I also should mention that this maternal antibody decay is not on a strict schedule. There's no, it decays this amount, by this time. Every foal is different. Every foal will start with a different level of antibodies, depending on their colostrum that they received, how well they absorb it, if they're sick. So if they're septic as babies, they go through these antibodies a lot faster than a normal healthy horse. And so there's no like, oh, on this day, we don't have to worry about maternal antibodies anymore. And on this day, we do. And I guess I also should say that, these boosters that we're giving, 5 more minutes, thank you. These boosters that we're giving, we have to give multiple, number one, so that the immune system is appropriately stimulated, no matter the age of the animal. But then we're also trying to dodge these maternal antibodies and make sure that the foal is getting multiple doses of vaccine when their immune system can respond. So next example, we have this foal, the made up foal, that their maternal antibodies has declined a lot faster than the first one. Let's say that this foal was sick and so used a lot more of their antibodies. And so in this situation, they have a much wider time frame where they are at risk in our arbitrary 4, example. And so we really need to make sure that we are not relying on our vaccines. Oh, the foal's vaccinated, so they're basically, like any other horse. They're not. And they really do require some extra care and protection. So kind of biosecurity basics, we want to separate groups of horses by age and or use. So don't house your show horses near your foals. It's important and useful. Quarantine new arrivals away from all your resident horses. And I know that's really easy to type on a slide and difficult to do in real life. I will just encourage you to do it as best you can and try not to have, oh, he's at the end of the barn aisle, that's his quarantine. It's really not enough. And I think, we get away with it a lot, thankfully, but when you don't, it can be really, really costly and you will kick yourself. So I don't think anyone ever said, I shouldn't have done that biosecurity, and then of course, wash your hands is easy to do, and then limit or avoid shared equipment between separate groups. So even if you can't have kind of a textbook quarantine situation, limiting cross, sharing of equipment as best you can go a long way. I did it in 20 minutes and less. So the question was, do you take any of this into account when you are thinking about weaning a foal? I would say no, because we don't know this information for each foal, right? I suppose, and when they either have it or they don't, right? So they're not getting more antibodies as they're closer to weaning age. So what's done is done, from that first initial neonatal period. Yeah, good question though. If you miss the third booster of this very important initial vaccination series, then you would treat that foal as an unvaccinated foal, and it would basically need another dose. So basically, then it would be an adult unvaccinated horse, and so you would need initial 2 series for most vaccines. That's not the same for every single type of vaccine. That's why those AEP vaccine guidelines are useful. So the question was, do we do titers for the longevity of these vaccines? In foals, certainly no. And there is not, other than the initial IgG test for a newborn foal to determine if they received enough colostrum or if they need more plasma, et cetera. There's not tests for, he's 2 months old, what's the antibody level. For adult horses, there is information available for titers against rabies and tetanus, but there's not, at least to my knowledge, good information for any other vaccines in horses as far as what's considered protective.
All right. My name is Jessie Tyma. I'm one of the surgeons at Rhinebeck Equine, and today I will be talking about large colon volvulus in the postpartum mare. So I just introduced myself. I'm part of the team at Rhinebeck. I get to do a little bit of everything with regards to surgery, emergency surgery, soft tissue, and orthopedics, and then also some sports medicine as well. Just as an overview of what we'll talk about here today, I'm going to introduce this topic, discuss the anatomy of the gastrointestinal tract and the large colon itself, a little bit of how this problem happens, talk about clinical signs of large colon volvulus and colic in general, diagnostics, important rule outs for this problem, treatment, what post-operative care looks like, how we can prevent this problem, what outcomes look like, and then review some take-home points at the end. So we're just going to start off by discussing what is large colon volvulus. So this is a subset of colic where we define colic as just the manifestation of abdominal pain in the horse. What happens with large colon volvulus is the colon itself, which is a part of the gastrointestinal tract, it rotates on its axis more than 360 degrees. It can rotate, I think, more than 720. It can keep going. And other names for this that are commonly heard are either a torsion or a twist. They're all referring to the same thing, volvulus being the most academic term, I would say. Why this is a problem is because when the colon twists like this, nothing inside of the colon can move. So the gas, the ingesta itself, it becomes obstructed and stuck. And the more serious problem is that with this degree of a twist, we're cutting off the blood supply to this really important organ, which is called ischemia. So not only is that organ itself not getting the oxygen and the nutrients that it needs through the bloodstream, but it is really obstructing the normal cardiovascular flow through the gastrointestinal tract. Why we're talking about this here today is because there's a predisposition in postpartum mares, and probably particularly in thoroughbreds, is something that's being investigated more carefully now. So I'm going to use the mouse here to point. Next thing we're going to do is go through the anatomy here in the gastrointestinal tract, really starting at the mouth, going through to a horse. We're going to envision ourselves that we are a blade of grass being eaten by the horse, and a nice pile of manure coming out the other side is the extent of our gastrointestinal tract. So we'll talk a little bit about the different parts of that and where this problem occurs and why that occurs. So this is a gastrointestinal tract that is basically just plopped onto this screen here. Looking all the way up here in the corner to the left, this is going to be our esophagus. So after a horse chews on a piece of hay, it swallows that bolus of food is going to move down the esophagus and into the stomach here. from the stomach, that partially digested food is going to move into the small intestine. The small intestine is all of the yellow that is shown here. This is actually about 60 to 70 feet of bowel, but it is not, and while that sounds really long, it is not really the bulk of their gastrointestinal tract. From the small intestine, that bolus of partially digested food is then going to move into the cecum, which is this big pink vat here in the corner. This is where a lot of gas starts to be produced, and we talk about a lot of fermentation and how horses are hindgut fermenters is really because of this organ. After the cecum, things are going to move into the large colon, and that's where we're talking about a lot of our problems occurring. I am going to carefully move through here. So we are in this area of the colon that is specifically, you can tell that there are these like sacculations. That's unique to this first part. We go all the way around the corner. This part is a little bit narrow. This is called the pelvic flexure, turns back upon itself. And then we've got this area that's non-sacculated up here in the dorsal colon, all the way down to here, transverse colon, small colon, into the rectum and out as a pile of manure. Where we are going to be talking about our problems is in this kind of rustish orange red color here, the large colon itself. And what I want to point out, and I'll get to a little bit more with the anatomy pictures in the next slide, is that this part of the colon right here, the pelvic flexure, this is not actually attached to anything inside of the abdomen itself, other than it is attached to itself right here through this piece of tissue that holds it together. Whereas other pieces of the gastrointestinal tract are rooted to a body wall. This area is free to move about, which is what causes a lot of colic, not just volvulus, in our equine patients. So taking a look at a couple more anatomy diagrams, we will start, everything on the left side is going to be normal here. So looking at the right flank, if we could just look right through the body wall, what we would see in a normal horse is that we're looking largely at the cecum here. The cecum is this large structure right here, and then our large colon sits a little bit in front of it, and on top of it here as well, we have this is the sacculated portion that I mentioned, and then the non-sacculated on top. This picture on the left bottom here is looking from the top of a horse looking down, and we can see the cecum on the right, and then you can see how the large colon is positioned inside of the abdomen in a normal patient, not having any kind of colic or malposition of their colon. Moving up to the image in the top right here, this is showing what a volvulus may look like from that right flank. So what is happening is the colon is twisting upon itself. The direction that it is showing here is the most common direction that the colon twists. And where this is showing the twist, which is at the base of the colon, near the junction of the cecum and the colon, is the most common spot that we're going to see this. And this is going to rotate upon itself. I hope I don't add to the confusion. The picture in the bottom right corner is actually a horse upside down, so it's going to be opposite from the other picture. And what you can see here is showing that degree of twist from when we were looking at this problem surgically. So from one more perspective, if we were looking at the back of a horse and the back of a horse's abdomen in cross section, looking at here we have the cecum, we have the dorsal colon and the ventral colon, and those are moving clockwise to one another to a point where that twists. And then again, talking about that distension, talking about that ischemia is going to cause other problems as well. So why is my broodmare susceptible? We do see this problem very commonly in broodmares. That doesn't mean that other populations are excluded, but it is something that this population is at risk for. And while there's no true scientific evidence that proves this, we know there is a susceptibility, likely because once parturition has occurred, there's so much extra room in the abdomen from how much space the foal was taking up, which allows the colon to migrate more and often twist upon itself. We're going to move on now to talking about the clinical picture of colic and what large colon volvulus in particular might look like when it is occurring. So to discuss the clinical signs, this entire list is a general list of clinical signs of colic. When we're talking about large colon volvulus, these are going to be some of our most severe manifestations of colic and of abdominal pain. I have bolded some of the more common, more severe signs. So pawing, looking at sides, excessive laying down, violent rolling. So these horses that just go down, throw themselves down, and you can't get them up. Horses that are standing there trying to stay on their feet, but just continuing to buckle at their knees. Inappetence is a more mild sign. That might be your first indication. A bloated appearance, that can happen pretty quickly. And then some other more mild signs as well. Lip curl, stretching out, kicking at belly, and decreased manure output are all things that we think about with horses with colic. So all things to keep an eye on. Again, the ones that are bolded are typically going to be the ones that we're seeing more commonly in this population. So what do you do if you note these signs, particularly in your postpartum broodmare? You need to call your veterinarian immediately. This is a now 5 minutes ago emergency. So call your veterinarian so that we can provide advice and have a diagnostic evaluation performed as soon as possible. The goals of having a diagnostic evaluation, a colic exam, having your vet look at your horse. The goals here are going to be to perform a triage exam. So to assess this horse's systemic status, look at their vitals. Are they shocky? What do we think is going on? Be able to localize that lesion with some of our diagnostics. Do we think that there are abnormalities associated with the large colon based on our initial diagnostics? To categorize the lesion. So when we talk about a volvulus versus a displacement, which is another way that the colon can misbehave in the abdomen, one might say, like I had mentioned previously, going through the anatomy, a volvulus is where we have evidence that the blood supply is truly getting cut off. A displacement is where the colon, it might be sitting in the wrong spot, but this horse is not getting shocky because we are not having that cessation of blood supply and that bowel ischemia. And then from there and from that evaluation, be able to formulate an appropriate treatment plan. I'm going to go through these diagnostics. I'm going to keep it a little bit gray area as to what we might do on the farm versus what we might do in the clinic, and talk about how we might make that transition, why we may make that transition, and when we might make that transition as we go. So this is essentially the full gamut of what we would do in a clinic workup, a lot of which can be done in the field as well. So on physical exam, we're looking at the horse's attitude. Is the horse very colicky? Is the horse dull? How is it behaving? Or is it bright and happy and acting quite normally, interacting with its surroundings? What is our heart rate? Heart rate is often an indication of pain. It can also be an indication of blood loss, which is an important caveat that I'm going to get to in a little bit. One thing about horses, so I mentioned that horses that have large colon volvulus exhibit pretty severe signs of pain. This is a unique condition where even though they are very painful, their heart rate may not reflect that. And that is just because of the anatomy of how a volvulus occurs and how it changes the blood return actually to the heart itself and how their cardiovascular system is going to adjust. So we may have a horse that's throwing itself on the ground and have a heart rate that's only mildly elevated. That's something that we see not uncommonly, but it's not an always never thing. A respiratory rate and temperature are going to finish off our vital parameters. We're also going to look at these horses' mucous membranes. A lot of times in the early states of shock, these horses will get brighter in their pink color than normal. And the capillary refill time, or when we press their gums to blanch them out, it's going to come back very quickly. There's a normal range of 1 to 2 seconds. Sometimes these are going to respond really fast. Later on in this process, as this horse is going to a less compensatory state of shock, these mucous membranes are going to start to look more purple. They may develop a toxic line, and that capillary refill time is actually going to get prolonged. And what that is showing us is how well their cardiovascular system is responding to what's going on in their abdomen. Going to look at their jugular refill. A lot of times these horses in this state of shock will have a prolonged jugular refill. So if we hold off on their jugular vein to grab blood, which is something that we're going to do, we may be aware that it seems really slow to fill. We're going to listen for gut sounds. A lot of times these mares are going to have diminished gut sounds all around, and feel digital pulses as well, if it is safe to do so given the situation and given the comfort of the horse at the time of the exam. We're going to palpate these horses, and some of the things that we may find with large colon volvulus is we may feel large bowel distension. Because of that large bowel distension, we may find that our normal landmarks are inaccessible. We may feel tight bands, and what that essentially is that we have distension of large bowel, and the bands that are associated with the large bowel feel malpositioned and are crossing in strange ways. That's really what that's reflecting, is that things are not in the correct spot, and there's either gas or feedback up related to that. Sometimes early in the case, these can also feel very normal, which is, considering how colicky these horses can be, If it has not, enough time has not occurred that we're not having distension of the bowel, or there's a twist in such a way that it's really pushing the colon forward into the abdomen, we may not be able to feel any abnormalities yet. Something else that was really important when we're doing this palpation is that we are evaluating the reproductive tract as well, trying to feel if there's any evidence of a hematoma in the broad ligament if the horse is soon postpartum, and ensuring that the source of pain is unlikely to be related, or likely or unlikely to be related to the reproductive tract, considering how close the mare may or may not be to recent foaling. We're going to pass a tube. This is pretty standard for any horse that we're evaluating for colic, where significant pain is being exhibited, or if they have an elevated heart rate. What we're doing here is we're assessing for and relieving any gastric distension that the horse may have. We are going to ultrasound these cases. I'm showing two images here, and what our ultrasound is showing us is that we are getting a picture of the margin of the abdomen. So we can see probably about 20 to 25 centimeters in. So it's not the whole abdomen, but we have regular landmarks that we reach for, called a flash ultrasound, areas on the abdomen that we know what normal should look like and what kind of information we are going to expect to get from that. So I'm showing two images here. On the left, here I will use the mouse since we have two. What this image is showing is increased thickness of our colon wall. So our colon wall is up against our body wall, which is up here. This is our colon wall in this highlighted area here, and this is a gas interface with the colon. And this increased thickness of colon wall is telling us that there is edema in our colon wall. This is very consistent with large colon volvulus, with all of the signs that I have shown thus far, and typically means that our colon wall is getting thicker as this process is progressing. The reason that the wall is getting thicker is because of the ischemia that's happening and the fluid that is backing up into that bowel wall itself. Hopping over to the right, and I just want to, just as a clarification, the depth of these images is very different. This is probably 20 to 25 centimeters. This is a much more zoomed image. And what we are looking at here are colonic vessels. Blue is our vein and red is our artery. And when we are able to image colonic vessels along the margin of a body wall, we know that we likely have a displacement of the colon, if not a volvulus as well. And again, the rest of our clinical picture is going to help us differentiate between displacement versus volvulus, but looking for these vessels and seeing these vessels may help support this diagnosis on our ultrasound as well. Moving on to blood work, this is something that may differ a little bit if this horse is being evaluated in the field versus in the clinic. Probably the most important thing that we're all going to reach for, field and clinic first, that everyone is going to have is this lactate meter, which is down here. Lactate is a value that when we're grabbing it from the blood is giving us a systemic picture of whether or not this horse is appropriately getting oxygen to all of its peripheral tissues. So when this value is elevated, we typically have concerns that this horse may have some degree of ischemia to its bowel in the context of all the clinical signs that we have already discussed. It's a really important number for us. There is some history of this number being used prognostically in these cases. We typically think of this value normal as less than 2. Anything over 2 is elevated, and we will use this number to help prognosticate as we move through the treatment with these cases and to be able to help with decision making as well. It is not uncommon for these guys to become hyperlactotemic quite quickly. So that's something that we want to know right away and may help us guide our initial fluid therapy even before we're making definitive treatment recommendations. Up here, we're looking at a micro hematocrit tube that is going to tell us our packed cell volume and total solids. Those numbers are going to tell us how dehydrated this animal is. Where those numbers are relative to one another is also going to give us an indication of if this horse is systemically declining, if they are sick. We think about these numbers, they will diverge from one another as horses look more sick. So having these at snapshots in time for these cases can be really helpful for us for prognosticating and decision making. I also am showing a CBC chem here as well. These are we're looking at the white blood cells, the red blood cells, again, some hydration status. if this horse, if our white blood cell count is really low and we have a lot of white blood cells potentially moving into our colon wall, we're thinking these horses are going to be quite a bit more sick. Typically, that's when this process has been going on for longer. And then our chemistry, we're looking at some of the other organs that are vital to be able to support these horses as they move through this really serious condition. Something that's really important to talk about when we're evaluating these horses for large colon volvulus are rule outs. And there's really one that I want to spend a few minutes talking about, and that's periparturient hemorrhage. So oftentimes, I think most of you are very experienced breeding farm associated personnel here. When we have a mare who is soon post-foaling that may be showing signs of colic, not only are we worried about volvulus, but we're also worried that this horse may have a uterine artery rupture. Either that uterine artery ruptures and it is contained within the broad ligament and they make a hematoma, and that can be really painful because they are bleeding into an enclosed structure, or that can break out into the abdomen, which is a much, much bigger area for them to be bleeding out into essentially. But oftentimes the clinical signs of these, the clinical pictures of large colon volvulus and periparturient hemorrhage can overlap a bit. How to differentiate? Some things that we think about are how far out are these mares from parturition? If we're talking about that first 24-hour period, we really need to make sure that we're ruling out hemorrhage in those cases. If we're talking about a mare that's 2 months out from foaling, periparturient hemorrhage is unlikely. That's not going to be on my differential list at that point. Sometimes the mares that are bleeding will act more agitated than acutely painful, and that's a bit of a gray area description. Their mucous membrane color, I had already talked about how our large colon volvulus mares may have mucous membranes that are looking brick red to slightly purple. These mares that are having these bleeding events are more likely going to look pale. And again, heart rate. Again, before I discussed how a lot of times in large colon volvulus, we see the heart rate not as high as we would think it might be with their pain. When a horse is bleeding, their heart is going to beat faster to be able to circulate their blood. So a lot of times these horses do have quite a high heart rate. So these are all simple signs that may help us, but really what's definitive here is that these mares need to be evaluated by a veterinarian, both palpation and ultrasound, to be able to rule this out before we make a definitive treatment plan thinking that this is a volvulus. This is just a picture here showing what an ultrasound image may look like, showing some blood in the abdomen. Typically mares that are bleeding out into the abdomen, that is not a good prognosis. Why this differentiation is so important is because we have very disparate treatment principles. For large colon volvulus, we are looking at transfer to referral hospital, an emergency colic surgery, and we're really talking about how time to getting that colon derotated or detorsed is going to affect our prognosis. For those mares that have periparturient hemorrhage, we're dealing with hemorrhagic shock. We want these horses, we want to promote clot formation. Transport is not typically going to be advised. So if we can make this differentiation with veterinary assistance off the bat, it's going to help us give both of these cases the best outcome that we can. So we're just going to focus on the large colon volvulus portion of this now. Transport to the hospital, as I've said, these horses need to go to the hospital for emergency surgery. It is important to not just think about the mare here, but also think about keeping the foal safe. There's going to be a foal by these horses' sides. However, your trailer setup is, perhaps if the mare is painful enough that she's throwing herself around, she's not thinking about her baby. Her baby's probably not old enough to keep itself out of the way safely. So making sure that there is a way to get them both safely as safe as possible to the hospital is wise. When these mares arrive, we're going to get started on treatment. Basically, as we are doing our diagnostics, we're going to get a catheter into these horses, and we're probably going to get them started on some resuscitative fluid therapy. They haven't already seen Banamine. We're going to give them Banamine. We may be giving them sedation just to keep them on their feet long enough while we're getting the information that we need to prognosticate and make decisions for definitive treatment. I mentioned this is all happening as we're working these horses up. And then when we're talking about our next step, which I keep alluding to surgery, we're going to get some broad spectrum antibiotics on board as well as far as their perioperative medications. So in general, these horses are invariably surgical candidates. Of course, if we feel that we have diagnosed a large colon volvulus based on our workup, these horses need to go to surgery. In general, when we're talking about colic surgery, indications for surgical management when we're evaluating a colic are if there's evidence of ischemia, which in these cases, we often are going to have that based on our blood work, based on our clinical picture. If we have horses that are in intractable pain that we are not able to control, which often these mares are, that's another indication to go to surgery. We have a worsening systemic status, which if we have an opportunity to look at these horses at more than one time point before making that decision, we are often going to see. And then another indication that I often talk about in less severe cases are just recurrent signs of colic. But like I started by saying in this slide, surgical management is the only way to go with these cases. I think an important question is what if surgery isn't an option for my mare? I think this is a realistic situation, just considering the economics of horses, the economics of breeding farm management. If it is and our colic workups, they're not always a black and white picture. There are some horses that walk a gray area sometimes. If it's a mare that is throwing herself on the ground and the clinical picture fits and surgery is not an option, she has zero chance of surviving this, and prolonging discomfort is not going to accomplish anything, nor is that fair to the mare. So we will recommend humane euthanasia in those cases. If they are walking a line where we feel like maybe their colon could just be displaced and not necessarily TORS, we may attempt medical therapy and then reevaluate them serially, usually in a pretty small time frame, if their signs of pain are controllable, to see if it is something that is appropriate for medical management. But typically this is surgery or euthanasia. So moving on to the surgery piece here, this diagram just shows what a colic surgery setup may look like. These horses are going to be under general anesthesia after inducing them with injectable drugs in an induction stall. We'll use a hoist and a monorail system to move them into the operating room and place them on the operating table on their back, which is what we call that dorsal recumbency. We have a surgical and anesthesia team of 3 to 5 people between, for us, that is a surgeon, an intern surgical assistant, an intern anesthetist, and 1 to 2 technicians in there as well. We make an incision right on their ventral midline. So that is from their umbilicus extending forward. That incision can be anywhere from 6 inches up to 18 inches. We'll normally start small, and based on what we find and what we need to do and what we need to access will affect how big that incision ends up being. Colic surgery can be 1 to 6 hours. It really depends, again, what is going on in there and what we need to do to be able to resolve the problem. And lastly, not all conditions that we are taking to surgery are survivable. At the end of the day, colic surgery is the ultimate diagnostic. So we are gathering information while we are in there to be able to make decisions moving forward. So in general, the goals of colic surgery, like I just mentioned, ultimate diagnostic tool. We want to fix the problem and relieve the pain. We want to correct physiologic imbalances that may be occurring otherwise. We're going to rely on our anesthetist to do that, and perhaps serial blood work during the process to make sure that we're meeting that horse's systemic needs while we're focusing on fixing what's going on in its abdomen. We're going to assess the health of the bowel that was affected by the colic or the volvulus. And through that, we need to maintain intestinal transit with anything that we do. So our surgical approach with these cases, we are going to manually correct the volvulus. This is very different case to case on how hard this is. Oftentimes this will be based on the degree of twist, how tight the twist is versus if it's a slow twist versus a very acute twist, how much fluid has backed up into the colon wall. And as fluid backs up into the colon wall gets harder and harder to handle carefully in this space. The level at which that twist occurs, I showed you in those anatomy images, the colon is pretty long. Some of it's much more easy to exteriorize than the rest of it. So where that twist is and where we're derotating that twist can certainly affect how easy or challenging that may be. And then we're also, once we have derotated that colon, we're also assessing the health of that bowel and whether that bowel is going to be viable for recovery or not. And if that bowel is sick, we're trying to already formulate our plan of how aggressive we're going to need to be with our supportive care post-operatively to be able to help these horses have the best outcome that they can. So when we talk about assessing bowel viability, some of the things that we're looking at is we're looking at the color of the bowel. I have 6 images on this slide, and I think it, you can see progressively worsening color. This first image that I have here, the colon just is maybe a little bit injected in color. Normal would definitely be a little bit less pink. This is the cecum being held up here. This is a pretty normal color, to getting to a pretty bright red. We can start to see some purples through here, some purples through here, and these two last ones are obviously post-mortem images, but just showing very unhealthy and abnormal bowel color inside of the colon. So this is the big U that we talked about. This is called the mesentery, and so this is where the blood vessels are. We're going to palpate these blood vessels and feel the quality of the pulses in the arteries. Is going to tell us how good the blood supply, how strong the blood supply is after the point of that rotation. Edema is us taking our hands and feeling the thickness of the bowel wall. We know how thick normal bowel wall should feel. It's actually quite thin. It's thin, but it's strong. As it gets thicker, it's quite obvious, and it becomes more challenging to handle in that way as well. And it also becomes heavy because it is thick with fluid that horse has moved into that wall, which again makes it more challenging to maneuver. We're talking about the level of the twist as well. I mentioned initially with the anatomy that most commonly these are happening at the base of the colon where the cecum and the colon meet, but they can certainly happen further down the colon as well. Typically, if they happen further down the colon, less of the surface area of the colon is affected, and typically it's a better prognosis. And if even if it's severe, we have more options of how to manage it if it is further away from the base. Something else that we're watching for is not only how things look when we first go in there, but after we derotate this colon, are we seeing improvement in these factors? Are we seeing the color improve? Are we seeing motility? Are we seeing our pulses improve? The edema is not going to improve in that time frame. We're going to talk a little bit about surgical decision-making as well. So after we have derotated and corrected the positioning of that colon, we have some options to consider at that point. We can recover this mare. Sometimes we need to do an enterotomy to be able to correct the positioning of the colon. What an enterotomy is making an incision. I'm actually going to jump back at the very at the part of the colon that we can exteriorize the most, called the pelvic flexure, and emptying out the contents inside of the bowel. If because of their urethra's backed up in there, it often helps just replace things in the proper position or help get things untwisted. If we open the colon to be able to empty out what's in there, it takes off any additional, it takes additional weight out of the colon as well. If the bowel is non-viable at a point, we may need to be talking about a large colon resection where we could be taking away up to 90% of the bulk of the large colon and creating a new path of intestinal transit for that mare to be able to survive. We may be talking about a colopexy, which is a fancy term for basically creating an adhesion between the colon, that free area of the colon, and the body wall, so that that colon can no longer move as much on its own inside of the abdomen. And in some cases, we may be talking about euthanasia as well, just based on the bowel viability and the bowel friability as well. We were going to spend a little bit more time talking about the resection and colopexy going forward. So thinking that these mares, we've made the decision to recover them. I like to think about colic surgery in general as 3 hurdles. Surgery is really just the first hurdle that we have to overcome. We still have 2 big ones ahead for these horses to be able to go forth. And really in our broodmare population, we're thinking about almost 4 hurdles where getting these broodmares bred and to have a live foal afterwards is going to be an important part of their future. So anesthetic recovery is the next big step after surgery. In general, across emergency and elective surgery, we have a 1% morbidity and mortality for equine general anesthetic cases. This is about 10 times as high as it is in small animal, about 100 times as high as it is in people. And this can be because of neuromuscular causes, musculoskeletal causes, respiratory or cardiovascular. Anytime that we're putting a horse under general anesthesia, these are risks that we undertake. Emergency surgeries are always at a higher risk than the general case population as well. And then moving on to the postoperative convalescence, this horse may have done really well through surgery and anesthesia. There's still a really long road ahead to support these mares to be able to get them out the door going home. So moving on to talking about that postoperative care and what that looks like. These horses are going to be under really intensive monitoring. We are going to be doing physical exams every few hours, monitoring their attitude. Once we start to reintroduce feed, their appetite, their fecal output, and we're going to be performing serial blood work to see if we know that these are likely to be sick cases, to monitor how their body is compensating for that, whether or not they're maintaining hydration and responding to the therapy that we are providing. Their treatment protocols can be pretty intensive. We are going to be focusing on pain management and fluid therapy, antimicrobials, anti-endotoxic therapy, something I'll take a minute to talk about in a second. We want to be promoting milk production in these cases that have a foal by their side, gastroprotectant therapy, digital cryotherapy, or ice boots. We're going to be thinking about incisional care, and then also a slow refeeding to get these mares eating again. So to take a minute, anti-endotoxic therapy, endotoxin is a big scary thing that we worry about with our with these cases. And what that is essentially toxins that get released into the bloodstream due to that bowel being, that bloodstream being disrupted with this problem. That can make these horses really sick and can affect other body systems as well. So we do everything to combat that. I'm going to move a little quickly here. I'm taking too long. What about the foal? In these cases that are really sick post-op, I would strongly consider a nurse mare. If the economics are there, there's a lot of demand on these mares' bodies just to be able to recover. So it's something that should always be up for discussion. Post-operative care. Expect about 5 to 10 days in the hospital, where our goals are going to be to slowly withdraw supportive care, transition them to all oral medications, monitor their incisional healing. At the time of discharge, try and have them on limited medications and tolerating a full diet. Common postoperative complications that we run into with these cases are pain and colic, endotoxemia, which I already mentioned. A lot of times these cases will get diarrhea because their colon has to recover. Their colon isn't working like it normally should to absorb fluids. Thrombophlebitis is an infected jugular vein. Again, with all of the cardiovascular abnormalities that these mares experience going into surgery with this problem, it's not uncommon when they are sick to have that as a complication. Laminitis is truly secondary to the endotoxemia that they're experiencing. Ileus means that their bowel just does not want to kick into gear. Not as common here as it can be in other types of colic, but any sick horse is predisposed to this. And then we always worry about adhesions or unwanted scar tissue in the abdomen anytime we go in there. I want to spend a minute to talk about recurrence. The recurrence rate can be quite high in these cases. For all large colon malpositions, so both displacements and volvuluses, we're looking at a 15% recurrence rate. If we have a horse, and this is very common in the broodmare population, that has had a large colon volvulus twice, after that point, the risk of recurrence is 80%. So it's really quite high. What can be done to prevent this? I already touched on this briefly when we were in the surgery slides. There are two options: a large colon resection, where we are taking a large part of the bowel out. The gray area shows what that can look like surgically, or a colopexy, where we're creating an adhesion to that free part of the colon to the body wall. So a colopexy benefits are that we're preventing recurrence and possibly saving the cost and the morbidity of additional surgery that these mares may undergo. This procedure is not without associated risks and complications that are written there. I'm going to move through these really quickly. And what is described in the literature, there are a lot of different ways to approach this and a lot of different recommendations about when is the appropriate time to do this. Talking about large colon resection, sometimes this may be the only option if the colon is non-viable at the time that we are in surgery. But that doesn't mean this is also something that we can consider on an elective basis once this mare has recovered to prevent recurrence at that time. The benefit of that being that we are working with healthy bowel tissue at that point in time. This picture here shows what the end of that colon looks like. You can see it looks kind of just like this clump of tissue, but reroute the intestinal transit. And because this colon is gone, these horses aren't going to displace. They may need some dietary modifications, but typically they tolerate this quite well. These horses going home from surgery, what we can expect. Already talked a little bit about what those medications might look like. We're going to recommend some incisional monitoring, exercise restriction. They will be in a stall for a month with hand walking and a round pen for a month, and then large paddock for a month, and then back to their normal life at 3 months. I close my colics with internal sutures, so we're not worried about suture staple removal, but that's going to vary between surgeons. And in our, bless you, in our thoroughbred population, we're recommending no live cover until 2 months post-op, just because of the fragility of that body wall. So to talk a little bit about outcomes, just to go through, this paper is out of a big hospital in Kentucky where they're seeing very quick referrals. Their numbers are very good for looking at these outcomes. They are in a quite a big study size. They're seeing 90% of these horses reach hospital discharge. That is their short-term survival rate. 82% of these mares that are then getting bred, and 67% are delivering at least one live foal. So those numbers are quite good. That is a little bit, that's going to be related to that referral population where a lot of these farms are extremely close to the hospital, and the time to get these horses on the table is really fast. In contrast, another paper, not that long, not that far time-wise from this last paper, is showing that the survivability and long-term prognosis for these cases, again, not in a broodmare population, but a more general population, is quite a bit lower, where only about 50% of these horses are alive at 1 year. So I think the thing that I want to draw on here is the difference in these case populations, and when we're getting these horses the proper treatment, which is to surgery, as quickly as we can, the outcomes can be quite good. Talking a little bit about the large colon modifications, should jump down to the bottom. There really isn't good data about outcomes following large colon resection, but we know that this can be very effective in eliminating volvulus going forward with these horses. After colopexy, despite the fact that there are some complications that are associated with this process, and some of these can have catastrophic complications, a lot of these horses are doing quite well and are producing live foals at a very similar rate. So ultimately, to improve your prognosis and outcomes, quick referral in a susceptible population, and consider a prophylactic procedure, especially in these horses that are repeat offenders. Here are some take-home points. I'm sure I am past time, so I'll let you guys, instead of jumping to my question slide, I will just leave this here, and I'm happy to answer any questions that you guys may have.
So just quickly to introduce myself, my name is Lauren Holley. I know we have a lot of Laurens, Lauras, all of that at the practice, but I'm the new internal medicine specialist that's working with Laura, as well as a reproductive fellow working with Lauren. And today I'm going to be chatting to you guys about dysphagia and foals. So why is milk coming out of the nostril? So once you've got through all the pregnancy stuff and tackled that hurdle, now you've got the hurdle of your foals. So there are a number of respiratory diseases that affect foals in their life. Today, we're going to predominantly focus on the neonate, so foals that are less than 7 days old, and particularly looking at our aspiration pneumonia, more specifically milk. So before I go into that, I just want to highlight what I'm talking about when I'm talking about the respiratory tract. So the respiratory tract is kind of divided into the upper respiratory tract. So we've got our nose, our nasopharynx, our throat area, and our trachea. And then we've got our lower respiratory tract, which is mostly the lungs. It's broken up into a number of other components, but the lungs is the lower respiratory tract. And then we've got our other components that are often closely related to it. So our cardiovascular system, or our heart, our diaphragm that helps us move air in and out of our lungs, and our ribs as well, which help us move air, and also our protective barrier. So these are that we're kind of going to focus on a lot of these things. Before I go on to specific respiratory things, I'm going to talk about the importance of a neonatal evaluation. This is typically recommended by veterinarians for any new foal shortly in the first few days after birth, ideally within the first 24 hours. It includes a thorough physical exam and evaluation of their vital parameters, which, if anything was abnormal, we could lead to further diagnostics for that foal's health and longevity. So we're looking at our heart sounds, if there are any murmurs that are going to affect athletic performance or longevity, our joint palpation, confirmation of their signs of infection, angular limb deformities, palpating our umbilicus as well, which is really important, as this is basically an open site to inside the foal, which is a common route of systemic infection as well. Then we have our specific respiratory system evaluation. So our nostrils, do we have symmetrical airflow, or do we have appropriate airflow coming out? Do we have any nasal discharge? Palpating the hard palate, which is really important. So those are looking for cleft palates and everything like that. So that's just sticking your finger in and feeling that. Palpating for rib fractures. Birth is traumatic. We want to make sure that we feel everything symmetrical. There's no pain there. And then listening to our trachea and our lung sounds as well. Most new foal exams do include a minimum of measurement of IgG. So as we have heard about before, foals are born with no antibodies of their own. They have a naive but competent immune system, so they can mount an immune response, but they really need that protein to signal what's bad. So IgG levels are really important. And if there are any concerns regarding the foal or health issues with birth or anything with the mare, sometimes additional blood work can be recommended, such as complete blood counts, looking for underlying infections, as well as SAAs and fibrinogens, or even chemistries looking at organ function. But at a minimum, it really should include an IgG because that is really important. So going on to signs of respiratory dysfunction, could alert you or your veterinarian that something is going wrong with the respiratory tract. So nasal discharge, you've got white nasal discharge, which could be milk, especially if it's more liquidy. You've got purulent or pus, which can be white, yellow, or green, generally thicker. Serous, so that's clear nasal discharge, which can, depending on the situation, be a normal thing as long as it's not all the time. Blood, which is red. Respiratory rate, so your newborn foals normally around 60 to 80. There is a variability with this, whether they're sleeping, running around, doing all the other things. And as they get older, it does decrease. So in younger foals, it's about 40 to 60. Respiratory effort is really important to look at. So do they have nostril flare? Are they really moving their abdomen to try and breathe? Are there any grunting, or is there exercise intolerance even in your foals at running around not very long and then getting tired and wanting to lie down? Coughing is not a very common sign in our neonatal foals. This is normally a subdued or relatively poor reflex, and it takes about several weeks to develop. So just because there is no coughing in your young foal doesn't mean you don't have a pneumonia or a respiratory problem. This takes some time to develop. Respiratory noises, so you've got stertors, which are more like a snoring, a harsher noise. Stridor, which is more high-pitched, and then your gurgling in your trachea. Sometimes you can hear that, or any sort of grunting. And then, of course, fever, which can indicate that there's some sort of inflammation or infection there as well. So you have milk out the nose for when moving on to our next bit of this talk. So now what you're going to do. So you do need to take immediate action and call your veterinarian, because this is considered an emergency. Not so much as like it needs to be done in the next 5 minutes, but definitely same day, because the foal does need to be muzzled and separated from the mare while waiting for the vet. And as all of us probably know, foals are up and down multiple times in an hour nursing. They need constant sources of nutrients. So the longer you have them muzzled and kept away from that important source of nutrients and hydration, the worse it's going to be for the foal. And keeping them still with the mare and allowing them to nurse, even though there are signs of dysphagia, it's increasing your risk of aspiration pneumonia every single time. So really important to have a vet out to evaluate them. So a typical sort of diagnostic plan for what you're going to be looking at. So physical exam, really important, looking at the overall health of the foal. How's their mentation? How's the rest of the foal doing? Your routine blood work, again, depending on the age, you want your IgG levels, inflammatory markers. So this is good for, do we already have an established pneumonia? Do we have anything else underlying that's causing this problem? So that's our CBC, our SAAs, fibrinogen. Sometimes the chemistry to look at other organ function, IgG. And then sometimes, depending on where we're at in the sort of process, you can look at selenium and vitamin E levels. And then ultrasound or radiographs, so some sort of diagnostic imaging to actually evaluate the lungs of that foal. So ultrasound is fairly easy to do on farm, with the caveat being that you're really only getting that surface of the lung. Basically, how ultrasound works, it's sound waves. So as soon as it hits air, all those sound waves are going to be reverberated back in the view of like basically a white line. And as you can imagine, the lungs are meant to be filled with air. So you're really only able to get the surface of the lungs because as soon as you hit air, it comes back. So if you have an established pneumonia, you might have changes in your lung ultrasound, but really radiographs are going to be much more sensitive for those early changes that haven't basically spread out to the outside of the lungs. So radiographs can be done on farm as well, depending obviously if we have the equipment out there, but that really can give us a more global view of how those lungs are looking. Again, later on in the course, or if we haven't found a common reason for why this is happening, certainly things like esophageal or barium studies can be done if you're looking for the more abnormal causes of dysphagia as well. Endoscopy is probably one of the most important things for diagnosing this. So that's where we actually use a video endoscope to go and look at the upper airway. So we're looking at the function of the upper airway. Do we have any abnormal structures? What is going on there? As well as then also looking into the trachea to confirm that we are actually getting that aspiration pneumonia as well. Often this is done post-nursing. So we sort of challenge the foal, put them on the mare, have them nurse, scope them straight afterwards. This is unsedated. They do not like it. But as soon as we sedate them, we are going to lose our ability to assess the function of that airway. So it does require good restraint. They are a little bit squirmy, but they all survive. It's okay. All right. So what is dysphagia? It's basically difficulty swallowing, which swallowing can be kind of separated into three phases. You've got your oral phase, your pharyngeal phase, and your esophageal phase. So your oral phase is initiated by nursing and movement of the milk from the mouth into the pharynx, so the back of the throat. Your pharyngeal phase is swallowing that's stimulated by closure of the glottis, which basically closes over your airway. And I'll go over a little bit of anatomy in a second. And it's the most complex. Now, I don't know if anyone, when I started writing this and reading all about all these other things, I sat there and I was like swallowing to try and figure it out. But when you do stimulate as well, you can even just, if you concentrate on it, you can see how many things possibly move when you're trying to swallow. So it is a very complex maneuver and there's a lot of moving parts with it. And then you've got your esophageal phase, so relaxation of your esophageal sphincters to allow the food to go into the esophagus, and then closure of them afterwards so the food only goes the one way and not coming out the other way. So there are a lot of different components, but the pharyngeal phase, so this back of your throat, is probably the most complex. So these are a number of possible causes of dysphagia in foals. So functional dysphagia, which is probably one of our more common causes, can be associated with prematurity or dysmaturity. Often just they haven't developed those pharyngeal muscles that they need. Neonatal encephalopathy or dummy foals. So that's their brain function isn't as good, so their nerve function isn't as good. Systemic illness or sepsis, or if they're debilitated, that can certainly influence it. There are a number of studies that have looked into selenium deficiency in foals, and they've found that affected foals don't have different selenium levels compared to unaffected foals. It was originally proposed as a cause of dysphagia and a cause of weakened pharyngeal muscles, but we just don't have the evidence that it's there. And the other thing to note is that it hasn't been reported with other signs of selenium deficiency, which is your like white muscle disease, so your skeletal muscle weakness. Again, it's not saying that it's not a component. We just don't have the evidence for it yet, and foals should be supplemented. So it is still a really important component, but we don't know if it's like the be-all and end-all cause for a functional dysphagia. So your esophageal dysfunction or reflux, these are not as common. So your megaesophagus, which can happen in Friesians, or your congenital strictures, also in Friesians. Structural dysphagia, so your cleft palates. Basically, there's a hole between your mouth and your nose, so you're going to have milk coming out your nose. Subepiglottic and pharyngeal cysts, persistent frenulum, guttural pouch, emphysema, and tympany. And then some of the more, again, not as common, you've got your HYPP horses, so your quarter horses that can sometimes manifest at a young age, not very commonly. And then botulism, depending on your area, and normally you have other signs for that as well. So for functional dysphagia in foals, it is a lack of coordinated swallowing versus those weak pharyngeal muscles. So it is found to be a primary diagnosis, so no other signs of illness in about 5% of foals. However, one study found that 50% of their foals were either premature or had signs of being a dummy foal. The premature foals were more associated with that incomplete development of the pharyngeal muscles, so the weak pharyngeal muscles, whereas your dummy foals were mostly that brainstem involvement because everything needs to be controlled by the brain. But again, not a primary diagnosis. They have these other issues that are causing this as well. One study found that 17 foals on one farm over a course of 2 years had dysphagia that was associated with hydraulic fracking and secondary water well contamination with polycyclic aerobic hydrocarbons, which someone who knows much more about that stuff would be able to explain that. But so there was an environmental source for this. But all foals either have evidence of milk in the nostrils or within the trachea after nursing. They certainly can have foals that have no milk coming out of the nostril and are still aspirating and still getting milk in their trachea. So if you have an aspiration pneumonia signs in a foal, it's good to kind of rule out as well, because you're not always going to get that milk from the nostril. This can be seen in otherwise normal foals. And they can have a normal to strong suckle reflex. So again, that oral phase of their swallowing is more normal, and it's mostly associated with that pharyngeal phase as well. So unless they're premature or extremely weak or have obvious cerebral dysfunction or sepsis, they can be normal as well. So a little bit of anatomy here when we're looking at our upper airway scope. So the first thing is a pharyngeal wall. So this is basically the area that's surrounding the top. So I can move a mouse, all this part here. So this is your pharyngeal wall. So this is really helpful with your swallowing. You've got your entrance to your trachea here. So this is your airway going down there that needs to be protected. Your arytenoids, which are opening and closing your airway up there as well. Your epiglottis, which is this triangular piece here that normally when they swallow, it basically flips up and covers your trachea. So the food goes over the trachea and into the esophagus, which you can't really see, but it sits at the top there. So food's got to bypass the trachea and go into the esophagus. So the epiglottis flips up and the food goes in. The pharyngeal walls are really helpful at stimulating all those muscles to do all those things. So our first video here, we can see this is an airway of a foal. We can see that pharyngeal wall is collapsed over. You can't even see the top portion of the arytenoids there. The foal is still breathing and doing all the other normal things, but everything is sort of collapsed down. So those are evidence of weak or collapsed pharyngeal wall muscles. There's a lot of mucus in the airway as well. I don't know if I can play it again. I was just going to play again. There is a lot of mucus and other things in there. So there is some evidence of inflammation or lack of swallow in there as well. But this is a classic, what it looks like to have a weak pharyngeal wall. In this video, it's a full upper airway endoscopy of a foal. So it's not sedated, so there is some movement. Here we can see there's a lot of inflammation around, but we're going to basically try and get into our trachea, which is just timing. And as we can see, as we start going in the trachea, we're starting to see this white bubbly material, which is milk in the trachea. So we have evidence that this foal is aspirating, even though the structures at the top looked fairly normal. We didn't have any big obvious defects, and we didn't necessarily have any significant pharyngeal wall collapse, but we do have aspiration here. So this is all the way down to the bottom airways, and we've got that milk, and even as they're breathing, you can see some of that milk come up. This is a more severe foal. So the tube that's going in is a tube into its esophagus. So this is a challenge for a foal that had been treated for a couple of days. We can even see the amount of milk post-nursing in this upper airway is a lot. And then as we go into the trachea, and it lets us, we've basically just got like a significant amount of milk that's sitting in their trachea, which is a perfect media for bacteria and a secondary bacterial infection causing pneumonia as well. You can even see just a puddle of milk in this foal. So this foal had already started to be treated, which is why it has that tube in. So this is a challenge, but a significant amount of aspiration there. So there is a sliding scale for how much they aspirate and how much dysfunction they have. So these are just a couple of stills of those showing the milk in the trachea and milk in the upper airways and everything. So then we have our structural causes of dysphagia. So our cleft palate, so basically separating our mouth and our nostrils. We've got a hole there, so when they swallow, instead of going back, it goes into the nostrils as well. This epiglottis here is also really ulcerated and irritated, but otherwise the milk's going to come here and also come this way. And as you can imagine, with this big hole, your function of you just even swallowing is going to be impaired as well with that. So there is a functional change, but it's from a structural component. We've got our subepiglottic or pharyngeal cysts. So this is underneath the epiglottis and it's displacing it. So you can imagine, again, you're going to get some sort of obstruction to the normal swallowing. Persistent frenulum. So underneath this epiglottis here, you've got the structure here that's more rigid, that's actually going to stop it from closing and doing its normal functions as well. So you're unable to completely cover the trachea and you're limiting the movement of your epiglottis too. And then you have a foal in the top right here with guttural pouch tympani, so air in the guttural pouch, which is basically going to cause a physical obstruction that's going to collapse that airway as well. So these are probably some of the more common structural abnormalities we get. So this video here is quite a severe subepiglottic cyst. Like you can't even see normal anatomy past it. So that thing that's moving is that epiglottis that you would have seen before, and you can't really even see the normal trachea moving there. And it's actually also displacing the soft palate above it there as well. I'll play that one once more. So as you can imagine, it'd be pretty hard to do what you need to normally do, especially as a baby that, you know, their brains aren't as advanced as they could be. And then here, this video is a little bit more difficult to see, so you may have to take my word for it a little bit, but this foal does have a cleft palate. Again, this one's got a feeding tube that's running through there, and you've got this little ulceration here, and the tissue that's basically flipped up from that lack of that soft palate there as well. But this one was a cleft palate too. Let's play that one. Okay. So some of the less common causes are your esophageal dysfunction or reflux. So that's that last phase of swallowing. Megaesophagus, as I said, can occur in Frisians. They can have collagen problems, so basically they get dilation. What we see in these images here, these are radiographs with barium swallow studies. So this is the barium is the more whiter looking thing within what would normally be the esophagus, and it's kind of pooling here. So this one did have megaesophagus. It can certainly be secondary to a persistent right aortic arch, which is an external compression of the esophagus within the chest. That causes a dilation in megaesophagus as well. Congenital esophageal strictures, which is this bottom radiograph here. We can see the dilation and the pooling of the fluid, the barium fluid here, and then the narrowing here, and then the esophagus on the other side. Diverticulums are more common in older horses, but in theory can occur. And milk is likely going to be observed in the nostrils even post-bucket feeding, because again, it's that esophageal the problem. They don't have any problem with the oral and the pharyngeal phase, but basically once it's in the esophagus, they keep it, it comes out. So all of these commonly lead to secondary aspiration pneumonia. As you can imagine, milk in the lungs is bad. Milk is not sterile. The lungs are meant to have air in them, so any sort of excess fluid is not good. So there is a need for broad spectrum antibiotics. It is a mixed population of bacteria. As you can imagine, it's coming off the mammary glands of a mare, going through the mouth. There's a lot of different bacteria in there. And early intervention is really important. The longer this goes on for, the more severe the pneumonia is going to be, and the longer the course of disease is going to be. So again, our diagnostics, you need to confirm aspiration, or if you find aspiration pneumonia, you should probably have a look and see if they're aspirating milk. Thoracic radiographs are really great to monitor progression. Again, you might not have those changes on ultrasound. Your radiographs are going to be more sensitive, but ultrasound certainly is a good modality to use as well. And then your blood work monitoring as well. So looking at your inflammatory markers, your fibrinogen and your SAA as well. So these are some radiographs showing an aspiration pneumonia. So on the left here, we have a normal radiograph. So black is what is normally nice aerated lung that we can see here. This is our heart. And then our abnormal radiograph on the right, we can see that all this area that's normally here is all fluffy and cottony looking, and that's an aspiration pneumonia and a typical aspiration pneumonia pattern in the foal as well. This is our ultrasound. So again, as I said, as soon as you hit air, you get that nice bright white line. So if you go deeper than just a single white line, you're getting areas that do not have as much air. Therefore, you got consolidation in the lung or pneumonia. So this is abnormal because we're not just getting a straight white line, we're getting a deeper image. And even here, you've got areas that have no air in them. So this is looking at that pneumonia too. So what are our goals of treatment for the dysphasic foal? So we need to stop repeated aspiration. We need to reduce the inflammation to improve function. We need to treat secondary bacterial pneumonias, and we need to give them time to improve their brain or nerve function and strengthen their muscles as well. So stopping aspiration. So this includes either a feeding tube to provide nutrition. Foals, as I mentioned, get up multiple times within an hour to nurse. That is obviously very, very managerially difficult to do, but a feeding tube can improve that. They can be challenged with these feeding tubes in. While they look big on the endoscopes, they are small, they're flexible, they can swallow around them. It does, however, often require hospitalization at the start, depending on the farm and the ability. It can be something that's done there, but placement definitely needs to be done with a veterinarian. And we try to feed them every 2 hours when they're so young, depending on the age, it can increase, but every 2 hours is typically at least what we're looking at. Bucket feeding is another option as well. So they're not lifting their head up and they're putting it down, so the aspiration risk is decreased. There is a requirement for training. Not all foals are going to take to a bucket immediately, so often they need feeding tubes in place at the start while you're training them onto the bucket, so that if they don't take the bucket, you can at least provide that nutrition. This is something that absolutely can be done more long-term on farm as well. Bottle feeding is not something I typically recommend for foals in general, as the risk of aspiration is generally higher anyway. And it's the same sort of thing as if they were nursing from the mare. So typically bottle feeding is not what we recommend for these guys. And you need to keep the foal muzzled. He's fine to be in with the mare as long as he can stay muzzled and that muzzle is tight. Foals are resourceful. Even if they can't swallow, they're smart at getting muzzles off. So just needs to make sure that it's tight so that they can irritate their mom with the muzzle, trying to nurse. All right, you need to stop inflammation. So anti-inflammatories are really important as well. You do need to ensure appropriate kidney function before doing long courses of banamine. Typically, they can get away with half doses for a couple of days, but anti-inflammatories can really help reduce that inflammation as well as treat a little bit of that bacterial pneumonia or the inflammation associated with it. Antioxidants and your vitamins are really important. So in our area, a lot of our soils are quite deficient in selenium and vitamin E. So most newborn foals here do get a vitamin E selenium injection. And a lot of foals, we do recommend having them on a vitamin E supplement, or even the mares previously, because we're notoriously low in this area. So making sure they're supplemented. These foals will get supplements with vitamin E. Your Elevate liquid is going to be your most readily absorbed. So it's the product that, while it's probably a little bit smaller than the bucket, you're going to get your best bang for your buck with that one. Milking out the mare versus pacifiers. This has kind of been recommended or looked at as well. So milking out the mare, making sure that they have no milk and letting the foal nurse to kind of strengthen those muscles. It's really hard to like completely milk out a mare. And I'm sure she's going to get really annoyed if you milk her out and then the foal's just banging on her the whole time. And honestly, I've never tried to pacify a train a foal, but I can't imagine that it's easy. But the theory is to try and strengthen those muscles, but I don't know if it's going to add any benefit to it. But if you can get a foal to suck on a pacifier, great. Is this going to create vices later in life? Possibly, I can't imagine that it's a habit that they'd get rid of. But anyway, it's been spoken about. So you need to treat your secondary bacterial pneumonia as well. So this is broad spectrum antibiotics. So if they're in hospital, we often do intravenous antibiotics, often some sort of broad spectrum with Naxal or a penicillin, and then potentially amikacin as well, depending on kidney function and how severe the pneumonia is. Certainly oral antibiotics on farm, so your SMZ, your Equisol or cefpodoxime, but they do need some sort of treatment of antibiotics. Nebulization of antibiotics can also be really helpful too, getting concentrations into the airway and also reducing the sort of systemic use of antibiotics. Typically for more severe pneumonias, this can be really helpful too. And duration really depends on the clinical case. It's easy to say, oh, they need antibiotics for 2 weeks, but it really depends on the foal. If you're going to continue to challenge it, every time you challenge it and it potentially fails, you potentially have initiated another form of aspiration. So as long as they're being challenged or have evidence of aspiration, they're going to need to be on antibiotics. And then normally we'll wait for sort of a normal CBC and fibrinogen and SAA. So this is why we need to recheck blood work. Radiographs tend to lag behind. So even though we still have some inflammation on radiographs and our blood work's normal, it doesn't mean that there's still aspiration, just still that inflammation is coming down. And as I said, no more aspiration. And time. So it is really difficult to predict how long these foals take to heal. Some can take weeks, some can take a couple of days. It really depends on what's going on with the foal. If it's a dummy foal, often it's once that all the other signs of them being a dummy foal resolve, the dysphagia will resolve. If they're premature, just as long as they get that their muscles strengthened and again more time to develop, they can resolve. If it's a primary diagnosis and we don't know why, there's certainly, I have unfortunately had some foals that just stay on the bucket forever and never go back onto the mare. It doesn't affect their long-term ability to eat or do anything. We have no evidence that that's a thing. So we don't have any changes in their athletic performance or anything like that. But there have been foals that just never regain that or never, not regain, they never had to start with, never gain that function. But it does require repeated endoscopy. So that's the other thing to consider. You know, if you've gone a couple of weeks of trying to do this, at what point do you just say, okay, it's now a bucket baby? But again, that is more intensive management wise. But depending on the primary cause, it can take a little bit of time. Prognosis, as I said, the majority of foals with a strong suckle resolve in about 5 days. If they are a dummy foal or premature, the sign improves as the other signs improve, and we are seeing no long-term complications with performance or feed apprehension or swallowing later on in life. It can just be intensively managed at the start. Great.
So the question was, can I talk a little bit more about banking colostrum? Yeah, so what we encourage farms to do that foal mares is we encourage them to use a colostrum refractometer to test the quality of the colostrum immediately after the foal is born. And so that way you know that you are storing good quality colostrum. If you don't have a refractometer, you talk to your veterinarian and they can point you in the direction of how to acquire one. They're not expensive. Okay, so that simplifies it. But they're usually like less than $50. Like they're super cheap. You can either get them so that they actually have the gradations of like excellent, good, fair, and then poor. Or you can get them where it's just a number. I think the number ones, that's what's it, Briggs refractometer, is that what it's called? And that is specifically, I think, from like the wine industry. So anyway, it's a really helpful way of being able to grade the quality of the colostrum that you are collecting so that you don't just collect poor or fair colostrum. I would say if you're going to bank it, and it's probably different for those of us that are doing it, but definitely excellent quality should get banked. And then like the high goods are, does anybody have a number cutoff that they're using? No? Okay. So there are some farms that will just look at like what's the color and the stickiness of the colostrum, and I think that can be helpful, but it's nice to have an actual number that correlates. And so then what you're going to do is you're going to clean off the udder, and then you're going to collect. Every farm does a different amount. We use like the Utterly Easy milkers, and those bottles are how big? 12 ounces, 16 ounces, depending on how easy the mare is to milk. You can either use an Utterly Easy, or you can take like a 60 cc syringe and invert it. Do you know what I mean? Where you cut off the end and then use the end, you flip it so that the plunger is the opposite direction, and it kind of fits against the udder in a easier. Some people like that, but either way, you're going to pull off at least, I mean, depending on how the mare is, like at least 6 ounces. And then we just freeze it in those containers. If you don't have an Utterly Easy bottle, you can use, some people have used like clean soda bottles or water bottles, and then you label it. I would recommend like filtering it so that you're not getting a bunch of debris in there, but you filter it, put it into the bottle, label it with the date, the name of the mare, and then also the quality. So like if you have a number, you put the number on it, or if you have like a grade, then you list the grade. You can use last year's colostrum for this year's mares. Typically, like 2 years out is a little less good. It does degrade over time. And if you thaw it, you never thaw it in the microwave, reminder, thaw it in like a warm water, hot water bath. And when you thaw it, if you freeze it again, there's degradation that takes place in that process as well.
Okay, perfect. The question was if acupuncture can be used to induce a mare to foal if she's gone past her due date. I don't recommend inducing a mare to foal.
I would be curious to hear what Dr. Pasch has to say on this subject, because I think that there are certain points that are recommended that acupuncturists avoid in pregnant mares, and they are a lot of times useful for delayed uterine clearance. I don't know. I mean, mostly we're afraid to like try those points unless it's definitely warranted. I've used those points in situations where the mare is clearly aborting, but that's a different situation altogether. So
yeah, I think I agree. Like, and I think that those points that we as acupuncturists avoid in pregnant mares are the points that are going to cause uterine contractions, but not necessarily start like the appropriate cascade to have a healthy foal or a live foal even. I will say in humans, a friend was recently acupunctured and went into labor like 6 to 8 hours later, using the points that we listed as ones not to use in pregnant mares. But it's very different because in mares, like, I mean, like we've already said, we don't want to induce mares typically because it's so hard to predict when they are truly going to be ready, when the foal is going to be ready. So I would say long answer long, probably not. But there are certain points that will cause uterine contractions.
Just to harp on the whole due date thing, it's like the 340 days is not a hard fast. This is their due date. Some mares take a lot longer, and it's all very mare dependent on how that foal is developing. So not to touch on any of the acupuncture stuff, that's not, I don't know anything about that, but like it's just the normal sort of average gestation length in horses. It's not that they are due, this particular horse is due that date. The foals really only mature later on, and it really depends on, you know, what the mare's doing. So we don't know for that mare what her actual due date is.
What is the minimum required semen concentration?
Okay,
Shipping?
so the concentration for shipment is going to be, the minimum is going to be 25 million sperm per mil. If you're using the basic extenders, if you're using that specialized beyond extender, the minimum is going to be 50 million per mil. Yeah, basically that's it.
Okay, another stallion question while we're on it. Can a stallion's diet affect the quantity and quality of sperm? For example, can an excess of protein reduce sperm production?
So I don't think that we have a lot of data on like macronutrients and feeds and things like that and exactly how they affect sperm. There's been a lot of very specific micronutrients that have been studied, and that's the ones that have been used to create a lot of the supplements that help with fertility. So I don't have like a feed recommendation that's best for a stallion other than something that keeps them generally overall healthy. But some of the things that improve sperm values are included in those supplements.
Is there any research to support how fertility in the stallion is affected by overconditioning or obesity?
Yes. And so actually, if the stallion is overconditioned, it actually puts a lot of fat around the scrotum, and that insulates the testicles, which heat is not good for sperm production. And so it can actually drop your sperm production if the stallion is overconditioned, for sure. The other thing also that I didn't mention is soy. There is some thought that soy contains phytoestrogens and may have an impact on fertility also. So some people try and avoid soy-based things in their breeding stallions, but I don't know that there's any concrete evidence about it.
One more stallion question.
Okay.
Does anyone have any experience or heard of people using the Equine mask on stallions to improve fertility and behavior? This is from a veterinarian. I had a client today ask me about it, and he was told by other horsemen that they have observed an improvement in stallion semen quality and that the stallions are happier and calmer when they wear the mask or place under lights.
So the behavior I can't speak to as much, but in terms of sperm production, absolutely. So because stallions are long day breeders, just like mares, they're kind of designed to have their maximal sperm output at the times when the mares are maximally fertile. And so their peak fertility and sperm output tends to be in the middle of the breeding season around May and June. And we can certainly move that earlier, that peak in sperm production, if we put them under a 16-hour lighting program, like Dr. Gosselin talked about this morning. And it does take some time for that to work. It takes time for the horse to recognize that the day lengths are getting longer, and it also takes time for the sperm to be produced. So you're going to want to start that around the same time that you're putting the mares under lights.
And so inside the barn, does it matter what kind of light bulbs?
Yeah, so inside, so it does matter the strength of the light bulb.
Like 200 watts.
Yeah, it has to be, and like I was talking about, like the most important part, because if you just put a 200-watt light bulb in a big space or in a stall where the ceilings are really high, that may not be enough. So it really does come down to, like, I think if you have photography equipment, you can sometimes measure the light that is emitted or with like yeah. And so that's where you can run into the 10 candles, like
Foot candles.
Yeah, foot candles. Thank you. 10-foot candles, which none of us know what the heck that means, but that's what they're referring to. So that's where you can use if you put your readers on and you walk around in the stall with a newspaper, if you can read that newspaper in all sides of that stall, then your lighting is probably okay. Yeah. So it doesn't matter where the light is coming from, if it's a fluorescent light or an incandescent light or so none of that matters. It's just that the light is being produced. I do think that and if you have a chance to reach out or check the Equilume page, it's worth it to look at that information. They have a lot of good research on there. They are talking, it does seem to be that they're really exploring blue light versus red light versus all this other stuff. But it's the same, like they're really exploring how that can help us with the management of these mares. And so that maybe we're getting away from something that's just turn the lights on and then turn your timer off after a period of time. So it's pretty exciting stuff.
So the question was if we're trying to get the testicle to drop into the scrotum, and the answer is yes. And we've been successful on several cases, actually getting 2 testicles distended to the point where we collect semen and it is motile. We have not gotten a mare pregnant off that one yet, though. Yes, the next question was, is there a certain point where you stop trying and you just scaled them? It's not a black and white answer. Because, you know, I did mention I worked on that 3-year-old and we were able to get him to drop. Would we necessarily want to breed that horse anyways because he might pass on retained testicles? No, but so gelding is always potentially an option, but the stopping point is not necessarily black and white.
One of the reasons why we were electing to use acupuncture in cryptorchids was to actually decrease the cost of the castration itself. So, right, when you think about the difference between a castration on a fully descended male versus a cryptorchid, that's a very different procedure. I mean, it can be similar, but it is like, and Dr. Tyma can talk about that in more depth. But there is a cost benefit analysis that goes into how many times are you going to do that procedure, and is it worth the acupuncture treatment costs versus how much the surgery is going to cost.
Yeah, if we're talking about an abdominal cryptorchid where that testicle is retained inside the abdomen, the safest approach is to do a laparoscopic procedure where we're making small keyhole portals and using small surgical cameras to be able to remove that testicle. But that's the safest procedure as far as the smallest incisions and the lowest morbidity. It is a general anesthesia procedure, but the cost of that is about, I would say, 2 to 3 times, at least in our hospital, what it would be for just a standard castration.
So the question was if we do an evaluation on received semen shipments and kind of in the same way that we would on an outgoing shipment. Is that right? Yeah. So yes, I always check motility at the very minimum to make sure that, you know, we have live sperm. In order to get a good evaluation of motility, we have to let it warm for 5 to 10 minutes in an incubator. And then I'll usually use my thermometer gun to check the temperature and make sure it's at body temperature when I'm looking at it. And I'll usually, if I'm concerned about it, I'll run it through our machine so I can get numbers. If it's really poor, I may contact the stallion station and let them know. Oftentimes, and we do this at our stallion station as well, save a sample back so that we can determine if something went wrong in the shipment or if something went wrong in the collection. And a responsible stallion station will take that seriously and try and make it right, or, you know, try and improve the semen. The other thing that I'll do if I'm concerned, if we got a really low amount, or if it looks really not concentrated on the slide, is I will run it through the nucleocounter and do all the calculations and make sure we have the minimum amount to get a fertile sample. Maybe Dr.
Pat, what do you do?
Similar. If it looks good, I will do sort of the basic cursory, but and you don't always know you have a problem until you do the preg check. But I think it's when it feels indicated to do a more extensive evaluation, I think it's definitely worth it. Sometimes, so the question was whether ship semen comes with all the appropriate information. And unfortunately, no. I mean, sometimes you will get, hopefully at least the horse's name is on it, but you know,
Not always.
no, sometimes you just get like a syringe of semen and I think for me, at least that plays into it too, knowing that I'm getting semen from like either a veterinarian that I know, like if I get semen that Dr. King made, I'm not going to do anything with it.
Thanks.
Or like some of the bigger like quarter horse studs or something that this is all that they do. It's not like I'm not going to look at it, but I'm going to sort of trust that they're just bigger numbers affected by everything too.
I think for me, it really sometimes depends on if I'm breeding the mare, like if we did counter to counter and it's 1 o'clock in the morning and I just drove to Connecticut, I'm going to be like, yeah, I'm going to look at that second dose. God willing, there's a second dose. Sometimes there's not though. In that situation, when you're doing counter to counter, there's a lot of times not. So I do think like, and maybe Dr. King, you can talk about like a lot of times if we evaluate the semen and we find it to be lacking, if we end up going through another cycle, there are things that we can do to help that semen. So you want to talk about that some?
Yeah. So there have been a couple of studies that came out in the last few years about reprocessing semen. So where we actually take that sample, put a cushion on it, spin it down, remove the extender, and then put it into new extender. And that can actually help the viability of that sperm. Sometimes I've also been reprocessing, like I talked about in my talk, that situation where you have a mare that might ovulate like on a Sunday night or a Monday. I might reprocess that semen and put it in Beyond if the stallion station didn't already give me a dose in Beyond. And then that way I can hold it for longer. And so we've been having some good success with doing that too.
So the question was if there's any efficacy and safety on the EHV vaccines on horses that are recently infected.
Latently.
Oh, latently infected? Right, latently. So herpes does produce latent infections, but the antibodies that we get from those latent infections do not last. We know that these antibodies don't last. You can certainly vaccinate them if you don't know that they're infected, but there's no point in vaccinating them if they are latently infected, because they have the disease. You're not going to cure the disease. You're stopping the vaccines, basically stopping them from getting it. So it's not going to be harmful. They're just going to have antibodies. It's the same as if they then got a latent infection during their course of their normal herpes disease and basically got antibodies, fought it, and went back to latency. So I don't think you're going to interrupt it as much. You're just probably not going to do anything, and you're not going to stop the spread of it. And
So like,
Can you say if you've vaccinated all of your horses against EHV that there's no way we can have EHV on this farm? You can't say that. No one can say we don't have EHV. That'd be great if we could, but equine herpes virus is just a really tricky virus. The latent infection means it can hide, is hiding even from the horse's own immune system, which is why it can't be cleared. And so there's no way to test for it in a live horse. You can look for it post-mortem, by looking at trigeminal ganglion and other lymph node, lymph tissue. But we can decrease viral shedding with vaccination, which is one of the multiple reasons to give it. We don't know which horses are latently infected. We suspect many of them are, but still reasons to vaccinate your herd, because you're going to have less virus in the environment if everybody is vaccinated, decreasing the risk that someone's.
Just to add, I just basically assume that they're all latently infected. And I think it's also really important to realize that none of the vaccines are fully preventative at all. They're not preventative of any of the forms of disease caused by EHV1. So the best we can do is give, in our breeding population, is give the high antigen vaccines to try to decrease viral shedding, as Dr. Schneider was just saying. So.
Yes, repeating the question, how do we prevent large colon volvulus? There are two prophylactic procedures. There's a colopexy, which is where you're creating basically a surgical scar between the part of the colon that's free to move about the abdomen and part of the abdominal body wall. That has a list of risks and complications, and generally significantly limits the chance of repeat volvulus or displacement. There's still up to about 5% that can recur, and there's a list of other complications associated with that. In heavily managed populations, it is recommended for repeat offenders, and there are many different techniques. And I think that the thing that's hard about the data that's out there is that it doesn't compare across techniques. It's all technique specific, and there's not one technique that is recognized as the ultimate technique for that. And different surgeons are going to select different techniques for different reasons. It can be done at the time of volvulus. It can also be done as an elective procedure at a time that the mare is healthy. I think recommending it after a single correction, there's going to be some debate of whether or not it is worthwhile to prolong anesthesia time to do that in a sick horse. There are a lot of factors that go into that decision. If the horse is having a second volvulus, that is where we're looking at that 80% recurrence after 2 volvuluses, 2 colic surgeries, 2 sick horse in the hospital, expensive hospitalizations, high morbidity, high mortality situations. So that's really where we're going to recommend that. A large colon resection, where we are removing up to 90% of the bulk of the colon, is the other procedure. Sometimes at the time of volvulus, if the bulk of the colon is not viable or able to recover from losing its blood supply, we will recommend that as really truly our only option to be able to recover that mare at the time of surgery. That is not a procedure to undertake lightly, because we are also creating a new surgical opening between bow that's very unhealthy because of this process. Similarly, this procedure can also be done electively as well in a repeat offender at a time when the colon is more healthy. This procedure, because we're really changing the surface area of water absorption, we may have some diet modifications that need to occur. There's a lot less data that says how well those mares do post-operatively, but you're really limiting any type of displacement or volvulus once they've recovered from that surgery. I'm going to repeat the question. Any time to limit it the first time? Yeah, no. And it doesn't happen in any mare by any means, but in every mare, sorry. But it is, they are predisposed. They do have this, like, all of a sudden they've got all the space in their abdomen and their colon does like to move. That also being said, it doesn't just happen in postpartum mares. Once in a while it happens in a gelding and we're like, oh, right, this does happen in other populations.
Yeah, the question about like preventing these things from happening is really tough, because of colic is something that is really difficult to prevent in general. As Dr. Tyma said, these volvuluses can happen a decent way postpartum as well. It can be like up to 150 days, it can take some time. But it's the same with any other horse, making sure that their diet is stable and everything else is as good as you can possibly make it. Hopefully you're then not reducing your risk, but it's unfortunately not a foolproof method. But obviously horses need as much as we can in our population, give them as much forage as possible to promote their normal healthy gut, normal bacteria, normal gas production and things like that. So stable feeding is really important in that too. And they are going through a lot of changes in that period with the foal and everything like that. So trying to keep it as routine as possible. And this is the way I like to view it, at least, is that horses are meant to graze, right? If you think about a wild horse, they're eating all the time. We know this, that they produce acid in their stomach all the time. They are meant to be eating all the time. So the way that sometimes we feed them with meals throughout the day is not natural. So having them have access to hay, all the time is going to cause them to forage, and that's going to keep their gut as happy as possible. So that's going to be what's best for them. And it's easy for me to say reduce the grain, but in a postpartum mare, she needs calories, and that's really important for her as well. So she will need that grain diet. That's just impossible for them to eat as much as they need to get the calories. But smaller grain meals is always better than one big massive grain meal a day. But absolutely, constant access to forages is important.
Dr. Gosselin asked about if there are management factors that lead thoroughbreds to be overrepresented, and not to my knowledge, no. And I think they're studying some genetic lineage, some heritability with that potentially as well. There's nothing solid on that yet though, as far as I'm aware.
Just two other quick comments. There is some research that's shown that there is a difference in the microbiome of postpartum mares that have large colon volvulus and those that don't. The problem is we don't know what to do about that just yet. So basically, just to emphasize again, like Dr. Holley was saying, their diet is really, really important. We just don't have a good recipe for how to manipulate their diet in the correct way. And we have, as a practice, we have had some farms that have had seemingly an increased incidence of large colon volvulus in a given year, or over a span of a few years at that farm compared to what they had had in the past. And we have really then focused on nutrition and done a lot of analysis of the hay and the pastures and all these things. Whether or not those changes helped or not, it's hard to say. It's such a multifactorial thing, but we do worry about, basically overproduction of gas in the large colon, which all comes from the microbiomes that live there. The other thing I was going to comment on, as Dr. Tyma was saying, that just to mention the Pexies, is to me, it's always a very different decision in a broodmare also versus any other horse that has recurrent large colon volvuli, because we're asking that mare to get pregnant every year and have a big giant uterus that expands in her abdomen. And so I always worry about, if we're pexing that colon down, what's going to happen the next year when the uterus has a giant foal in it and is put, normally the colon kind of moves out of the way. It's not a benign procedure. That's just why we don't jump to it the first time they have a volvulus. It's very different. Like if any of you have deep chested dogs, they very commonly are pexing the stomach to prevent a GDV, which is like the dog version of this, but those are not brood mares. So it's a different calculation.
And I didn't say this explicitly, but the most significant risk and complication there is that the colon can rupture catastrophically, and that is not a survivable condition. Sure thing. So the question is about dietary or management that need to change after large colon resection. And I will just put a caveat that I don't think this is necessary for every horse that has a colon resection. I think some don't tolerate as much of a stable forage diet as they may have previously, only because you have greatly reduced the surface area with which they are like in which they have that microbiome that is processing that forage. So I think it's going to be a little bit mare specific, mare horse specific. How much colon is taking too. You're not necessarily always taking 90%. You may be taking less than that. Some horses do have loose feces or like softer feces regularly after that, because you're also reducing the absorptive capacity of the colon just by surface area. So a little mare specific. And I think some horses do fine on quite a normal diet after that procedure, but some may need either reduced bulk or you may just live with some soft feces.
What's interesting about the horse is actually in the hindgut, the horse doesn't break down any of its food, it's the bacteria. So the horse isn't digesting anything. So without that bacteria, it's not going to be able to, ferment and break down cellulose, which is in our haze and everything. So it as Dr. Tyma said, it purely depends on what bacteria and stuff are there, which depends on how much mass and everything you have, and can be very horse dependent, whether they grow that back and what they have. The question was regarding diet and nutrition recommendations for pre and postpartum mares. So definitely, besides just purely that they need the calories to make a foal, to then start producing enough to lactate, so they do need a decent amount more calories. But what I'll talk about is mostly the vitamins. So vitamin E, which I mentioned before, is actually really, really important for them. It's something that is notoriously low in our area. I do think that providing that is going to provide the best for the foal. It's also really important in a lot of cellular functions, including the immune system and antibody production. So you are going to actually improve their immune system and therefore improve colostrum, improve the foals, but also you need it for so many other things. So a lot of mares, it's best to actually supplement them with vitamin E, and the liquid elevate is what we know is the most absorbed. So you can use a lot lower doses of the liquid elevate compared to the powdered elevate. There are bunch of vitamin E supplements out there. A lot of them are not absorbed. The horse needs a very specific formulation to actually absorb it. So Elevate is probably the most reliable and the one that I would typically recommend for these guys. So a lot of mares probably need somewhere around the 4,000 to 5,000 units a day of vitamins, and then definitely increase calories, often like a senior feed or a mare and foal feed post and pre. And
yeah. Just from like a purely caloric standpoint, I think it's a common misconception that like as soon as the mare is pregnant, you need to increase your calories, and that is not in any way true. That'll just leave you with a fat mare, and that's not going to help with fertility. So the highest like metabolic demands are going to be during lactation. So it's late pregnancy and then the postpartum period. So from, again, just thinking about calorie intake, that's when you need to feed them the most. If I have mares who are already obese and don't regularly get grain as part of their diet, I will recommend that they go on a ration balancer so that we're at least addressing most of the big ones without adding significant calories from the grain.
When you are recommending a ration balancer, are there any that you aim people toward?
Not necessarily.
Okay. I know, like,
I tend to go
like
for Yeah, I mean, for me personally, I tend to go with sort of the reputable feed companies that have done the research and can actually show what is in the ration balancer.
Okay.
But I usually, because I am far from a nutritionist, will say to just follow the label instructions. Okay, so we'll all chime in. But the question was about specific recommendations for a high school student that wants to go on to become a veterinarian. I took a very non-traditional path to become a veterinarian. So without going too much into it, like I was an art major. So you can do whatever you want. And I think no matter what path you take to get there, it's going to influence how you practice and how you view veterinary medicine differently. I think it's certainly colored how I also came to this career later in life. So I think making sure doing whatever you need to stay interested and sort of convince yourself that you have that passion and that interest. And that's the most important thing. I think we all probably took different routes to get here.
Yeah, I concur with what Dr. Pasch said about we all took very different routes. As much as you can broaden your experiences as you're leading up to your vet school application, just to know there's so many different facets of what we do. We are a very, very narrow aspect of veterinary medicine and what a degree in veterinary medicine can provide you as all equine veterinarians here. There are so many things outside of equine medicine, outside of private practice that veterinarians do. Dr. Schneider is a great example. She works in industry, but she also is a part of like the equine veterinary medicine community. So there are so many different paths. So getting experience and having opportunities to shadow with people who to experience veterinary medicine differently, I think will help you go into your interviews and into the application process with just a more worldly view of what those choices look like going forward.
I'm gonna just generalize here. Most veterinarians are type A, and I'd say you're probably type A since you showed up here today and asked this question. So I'm sorry that I'm generalizing, but because of that, I think it's important to also remember that your path to veterinary medicine, if that's what you choose, might not be linear, and stick with it if that's what you want.
Yeah, so the question was about deworming
protocols for
in general. I mean, I think, and I'm not trying to be give a cop-out answer, but I would really recommend talking to your veterinarian because there are so many variables that go into it. There's not like, oh, if you do this, then all will be well. There's also, and I'm like a broken record, but on the AEP website, there's internal parasite control guidelines that lots of really smart people have spent a lot of time putting together. And I don't know that they specifically talk about broodmares in there. Like off the top of my head, I don't remember that they do.
I think it's a line. Yeah.
It's a line. Okay. So it's in there. It's a long document, but they did a good job of like putting some highlight boxes in there that would really give you a lot of information that I don't have time to go into here.
The immunity that foals have to parasites they are not small adult horses. They're very different. So I think it's worth it to understand that, at least for me, I am more aggressive on how I deworm my young horses versus how I deworm my older horses. And I do think that you should talk to a veterinarian who has experience deworming young horses and managing young horses. I think that's very important.
Not deworming young horses properly means they end up with me with very, very strange lesions that are very unique to that population and oftentimes do not carry a good prognosis.
Yeah, I'm cheaper than she is.
Yeah. Yeah, and it's definitely a lot more complex than fecals and your routine deworming. You know, our fecal flotations that we're looking at are really only can find certain parasites. There's a ton of other parasites that foals need to be covered against. So normal deworming of foals is really important, and also, you know, targeting the mare. But it definitely talk to, you know, your local vet, because it's a lot more than just fecals deworming and things like that when they're pregnant and when you have foals.
I'll just add one brief thing, which is that I really push all of our farms to do fecals on groups of foals routinely. And then specifically what I'm looking for are those foals that are high shedders. So we can do proper fecal egg count reduction tests, which is really, it's a very crude measure, but it's still the best measure we have of detecting resistance on your farm, which is really important. That's why we can't just come up here and say this is a blanket recipe for how to deworm all your mares and foals, because the parasite population on your farm is different from the parasite population on the farm down the road. And what we're really trying, all of our efforts now are geared towards keeping your animals healthy, but also decreasing resistance, or I should really just say slowing the progression of resistance amongst the worms to our dewormers, because there are no new classes of dewormers on the horizon, and there is increasing resistance to all of the existing classes. So it's not a great situation. And so really trying to figure out what is going to work best on your farm is really, really important.
So the question was bucket feeding foals and issues with getting them on the bucket. And yes, it can be extremely difficult. Certainly, if you are in that transition, making sure that they're hungry is number one. So while we do have the feeding tube in them to get that nutrition into them, normally skipping a meal so that they are hungry will stimulate that, and they'll figure it out. Because once they figure it out, they're normally pretty good. Otherwise, some people do put things like carrot syrup and stuff in it to make it taste nice. Changing, your milk replaces, adding mare's milk. Some foals are very particular about the taste of things like that, which can be extremely frustrating if you have one milk replacer, or if you're using mare's milk or a mixer of both, or the mare's not producing and you need to use a milk replacer. So playing around with those things can be really helpful, but the honest thing is it's persistence. Sometimes some foals will take to it really well, and some foals need a lot of work, and there's unfortunately no magic bullet to figure out what to do, but just trying a bunch of different things like that.
I think a lot of times we can't get weak as humans. We're like, oh, we just want to give a bottle, or that's obviously not going to help with dysphagia, but we get weak, and then we don't stick to our guns.
The other thing is that bucket babies can act similar to orphan foals, in the sense that they see you as their food source. They can be a lot more familiar with you. So you do need to make sure you set the boundaries for them, and you need to make sure that you discipline them when they do things that are wrong, because otherwise they're going to end up you're going to end up with a foal that's basically on top of you all the time and can be dangerous. So it's the same sort of thing as like an orphan foal syndrome. So you do need to be disciplined with them and make sure that you kind of separate that sort of feeding behavior from just you, and still have that normal interaction with other horses. So sometimes having them still in with the mare can actually be really helpful, because the mare is great at disciplining the foal when he or she misbehaves. I say he because honestly, I swear the colts are worse when it comes to that. But trying to separate those behaviors and make sure that they don't see you as just that food source and can be overexerting is important. That being said, you can also try and bucket feed under the mare. That's the other thing you can try, which I have tried in the past. It's just very annoying. I swear I've had one foal that I don't even think it like truly bucket fed and went on to like milk pellets, and I was like, that makes sense.
Enough to drive.
Thank you so much for joining us, those that joined us online. It was an absolute pleasure to have you. Again, any questions, comments, or feedback, you can send to hello@cavalcadeeducation.com. And we will see you at the next one.